Why are you interested in specializing in stroke rehabilitation nursing? What aspects of this field resonate with you?
I am deeply interested in specializing in stroke rehabilitation nursing because it aligns with both my clinical interests and my personal values as a nurse. Throughout my experience in general medical surgical wards, I found myself particularly drawn to patients recovering from stroke. What stood out to me was the resilience of these individuals and the vital role that nursing care plays in restoring not just physical function, but also hope and dignity. Stroke rehabilitation is unique in that it combines evidence-based interventions with highly individualized care, and I find that balance both challenging and rewarding. My interest also stems from witnessing the long-term impact that focused rehabilitation can have on a patient's quality of life. I once cared for a middle-aged patient who had experienced a severe ischemic stroke. Initially nonverbal and fully dependent, she made remarkable progress with consistent rehabilitation and nursing support. Being part of that journey, celebrating small victories like her first steps or regaining her ability to feed herself, deepened my commitment to this field. I realized that stroke rehabilitation isn't just about physical recovery. It's about restoring identity, confidence, and independence. Additionally, I am passionate about patient education and interdisciplinary collaboration, both of which are central to stroke rehabilitation nursing. I believe in empowering patients and their families with knowledge, helping them understand the recovery process and how to manage risk factors for future strokes. This proactive, holistic approach resonates with me deeply as it aligns with my long-term goal of promoting sustainable health outcomes. Ultimately, I see stroke rehabilitation nursing not only as a career path, but as a meaningful way to contribute to the broader goal of rebuilding lives after neurological injury. It allows me to combine clinical expertise, empathy, and a commitment to lifelong learning, qualities I continually strive to uphold as a nurse.
Tell me about your previous nursing experience. Do you have any specific experience in rehabilitation or with neurological patients?
Over the past 2 years, I have worked as a registered nurse in a dedicated stroke rehabilitation unit, where I provided comprehensive care to patients recovering from ischemic and hemorrhagic strokes. This experience has been both professionally enriching and personally fulfilling. In this role, I was responsible for assessing neurological status, managing medication regimens, supporting mobility and activities of daily living, and collaborating closely with physiotherapists, speech and language therapists, and occupational therapists to deliver a coordinated care plan. One of the key aspects of my work involved patient and family education, helping them understand the recovery timeline, potential complications, and lifestyle modifications necessary to prevent recurrent strokes. I found that effective communication and emotional support were just as important as clinical interventions, especially when patients were adjusting to new limitations or experiencing frustration with slow progress. During this time, I developed strong skills in neuroassessment, wound care related to immobility, and the use of assistive devices. I also participated in interdisciplinary team meetings to evaluate patient progress and update rehabilitation goals. One of the most rewarding parts of my job has been celebrating milestones with patients, whether it was their first successful step after weeks of therapy or being able to feed themselves again. This experience has strengthened my confidence in providing holistic, patient-centered care and has deepened my interest in advancing my career in stroke rehabilitation nursing. I've seen firsthand how structured rehabilitation and compassionate care can transform outcomes, and I'm eager to continue growing in this specialty.
What do you find most rewarding about working with patients recovering from a stroke?
What I find most rewarding about working with patients recovering from a stroke is the opportunity to be part of their journey toward regaining independence and reclaiming their lives. Stroke rehabilitation is often a long and emotionally challenging process, but it's also filled with moments of resilience, determination, and progress that are deeply inspiring. Being able to support patients through some of their most vulnerable moments, and then witness their gradual improvements, whether it's learning to speak again, taking their first step, or simply performing daily tasks independently, gives a profound sense of purpose to my role as a nurse. Each patient's recovery is unique, and I value the individualized care that stroke rehabilitation requires. It allows me to build strong therapeutic relationships, understand each patient's goals, and tailor care in a way that's both clinically effective and emotionally supportive. The trust patients and families place in us during such a critical time is something I take very seriously. Moreover, I find it incredibly fulfilling to educate and empower families, helping them understand the recovery process and how they can actively participate in their loved one's progress. Knowing that my care and encouragement can directly impact someone's motivation and outcome makes this specialty incredibly meaningful to me.
What are some of the biggest challenges you perceive in stroke rehabilitation nursing, and how do you approach them?
One of the biggest challenges in stroke rehabilitation nursing is managing the emotional and psychological impact of stroke on both patients and their families. Recovery is often slow and unpredictable, and it's common for patients to experience frustration, depression, or anxiety, especially if they are dealing with communication barriers or loss of independence. As a nurse, it can be difficult to watch patients struggle emotionally, even when their physical recovery is progressing. To approach this, I prioritize compassionate communication, active listening, and emotional support as part of daily care. I also collaborate closely with psychologists, social workers, and speech therapists to ensure the patient's mental health is addressed alongside physical rehabilitation. Another major challenge is maintaining patient motivation over time. Stroke rehabilitation requires consistency and effort, and it can be discouraging when progress plateaus. I've found that setting small, achievable goals and celebrating every milestone, no matter how minor it may seem, helps patients stay engaged and hopeful. Encouraging family involvement also plays a crucial role, as loved ones can offer emotional encouragement and practical assistance during the recovery journey. Additionally, managing the complex medical needs of stroke patients, such as preventing complications from immobility, managing dysphagia, and monitoring for signs of recurrent stroke, demands constant vigilance and up-to-date clinical knowledge. I make it a point to stay informed on best practices and evidence-based protocols, and I never hesitate to seek input from the interdisciplinary team to ensure holistic care. Ultimately, while stroke rehabilitation nursing presents unique challenges, I view them as opportunities to grow both professionally and personally. These experiences have taught me patience, resilience, and the importance of teamwork in achieving the best outcomes for patients.
Where do you see your career in stroke rehabilitation progressing in the next 5 years?
In the next 5 years, I see my career in stroke rehabilitation evolving both clinically and academically. I aim to advance my clinical expertise by pursuing specialized certifications in neurological rehabilitation and stroke care, which will allow me to provide even more evidence-based, high-quality care to my patients. I'm also interested in taking on greater leadership responsibilities within the rehabilitation team, such as mentoring junior nurses or contributing to quality improvement initiatives that enhance patient outcomes and streamline care processes. Additionally, I would like to be involved in patient education and community outreach, helping raise awareness about stroke prevention, early intervention, and the importance of rehabilitation. Long-term, I am considering pursuing further studies, possibly a master's degree focused on rehabilitation nursing or advanced practice, to broaden my scope of practice and contribute to stroke care at a policy or program development level. Ultimately, my goal is to be a well-rounded stroke rehabilitation nurse who not only delivers excellent bedside care, but also plays a part in advancing the field through leadership, education, and innovation.
What motivates you to provide high-quality care to individuals recovering from a stroke?
What motivates me to provide high-quality care to individuals recovering from a stroke is the profound impact that nursing care can have on their recovery journey, not just physically, but emotionally and socially as well. Stroke survivors often face sudden and life-altering challenges, and knowing that my support can help restore their independence, dignity, and confidence gives deep meaning to my work. Each patient has a story, a family, and personal goals, and I feel a strong sense of responsibility to help them reclaim as much of their life as possible. I'm also motivated by the complexity and depth of stroke rehabilitation itself. It demands critical thinking, empathy, patience, and a strong understanding of neurorecovery, which continually pushes me to grow professionally. The interdisciplinary nature of the field, working alongside physiotherapists, occupational therapists, speech-language pathologists, and physicians, fuels my motivation as it reinforces the team effort required to achieve the best possible outcomes. Most importantly, it's the small but powerful moments, like a patient smiling after achieving a new milestone or a family member expressing gratitude, that remind me why I chose this profession. These moments reinforce my commitment to delivering care that is not only clinically excellent, but also compassionate and personalized.
Why are you interested in working at our specific rehabilitation facility/unit? What do you know about our stroke rehab program?
I'm particularly interested in working at your rehabilitation facility because of your strong reputation for delivering comprehensive, patient-centered stroke care, as well as your commitment to innovation and interdisciplinary collaboration. From what I've learned, your stroke rehab program not only follows the latest evidence-based protocols, but also places a strong emphasis on personalized treatment plans that address the physical, cognitive, and emotional needs of each patient. That holistic approach is something I deeply value and strive to uphold in my own practice. I was especially impressed by your facility's integration of technology in rehabilitation, such as robotics, virtual reality, or advanced gait training equipment, which reflects your dedication to improving functional outcomes through modern methods. I also understand that your program encourages family involvement and emphasizes patient education, which I believe are critical elements in long-term recovery and stroke prevention. In addition, I appreciate that your team includes a wide range of professionals, from neurologists and rehabilitation physicians to speech therapists and clinical psychologists, working together to provide coordinated, high-quality care. That kind of interdisciplinary environment is where I thrive, as it allows me to learn continuously and contribute meaningfully to shared goals. Overall, I see this as a place where I can both apply my existing skills and continue to grow as a stroke rehabilitation nurse, while being part of a team that is truly dedicated to helping patients rebuild their lives.
Describe your understanding of the different types of stroke and their potential neurological deficits.
There are three main types of stroke: ischemic stroke, hemorrhagic stroke, and transient ischemic attack, each with distinct causes and potential neurological deficits. Ischemic strokes are the most common, accounting for approximately 85% of all strokes. They occur when a blood clot or plaque blocks a cerebral artery, reducing blood flow to a part of the brain. Depending on the area affected, patients may experience deficits such as hemiparesis or hemiplegia, usually on the side opposite the stroke, aphasia if the dominant hemisphere is involved, visual disturbances, or impaired coordination and balance. Cognitive changes and memory difficulties are also common, especially when the frontal or parietal lobes are involved. Hemorrhagic strokes result from a ruptured blood vessel causing bleeding within or around the brain. This type can be further classified into intracerebral hemorrhage, within brain tissue, and subarachnoid hemorrhage, in the space surrounding the brain. Hemorrhagic strokes often have more severe symptoms due to increased intracranial pressure, including sudden severe headache, nausea, loss of consciousness, and neurological deficits like weakness, vision problems, or speech impairment. These strokes can also lead to long-term complications such as hydrocephalus or seizures. Transient ischemic attacks, TIAs, are often called mini-strokes because they involve temporary blockage of blood flow to the brain, usually lasting less than 24 hours and often resolving without permanent damage. However, TIAs are serious warning signs of an increased risk for a full stroke. Patients may experience brief episodes of numbness, weakness, confusion, difficulty speaking, or loss of coordination. Overall, the neurological deficits caused by strokes vary depending on the location, size, and type of stroke, but can include motor and sensory loss, speech and language difficulties, vision changes, cognitive impairment, and emotional or behavioral changes. Understanding these patterns is essential in developing targeted rehabilitation plans and supporting each patient's recovery.
How do you assess the neurological status of a patient post-stroke? What specific assessments are crucial?
Assessing the neurological status of a patient post-stroke is a critical and ongoing process that helps guide treatment and rehabilitation planning. My approach begins with a comprehensive neurological assessment, focusing on both initial evaluation and continuous monitoring for any changes. One of the key tools I use is the National Institutes of Health Stroke Scale, NIHSS, which provides a structured and standardized way to measure the severity of stroke symptoms. It evaluates areas such as level of consciousness, gaze, visual fields, facial symmetry, motor strength in the limbs, coordination, ataxia, sensory response, language abilities, and attention. This scale not only helps in identifying the stroke's impact, but also in detecting early signs of deterioration or improvement. In addition to the NIHSS, I conduct frequent neurological observations, including checks of pupillary response, orientation, person, place, time, speech clarity, and limb movement and strength. I also assess cranial nerve function, which can indicate specific areas of brain injury. For example, difficulty swallowing, cranial nerves 9 and X, might prompt a referral for a swallowing assessment to prevent aspiration. I pay close attention to changes in vital signs, as alterations, especially in blood pressure or respiratory rate, can signal increased intracranial pressure or further complications. Glasgow Coma Scale, GCS, scoring is also useful, particularly for hemorrhagic strokes or patients with altered consciousness. Beyond the physical exam, I monitor cognitive function, emotional state, and behavioral changes, as post-stroke depression, confusion, or impulsivity are common and can significantly affect recovery and safety. Overall, regular, systematic, and thorough assessments allow me to detect even subtle changes early, advocate for timely interventions, and contribute meaningfully to the patient's rehabilitation goals.
Discuss your experience with managing common post-stroke complications such as dysphagia, communication deficits, aphasia, dysarthria, motor impairments, cognitive deficits, and emotional lability.
In my 2 years of experience working in stroke rehabilitation, I've developed a comprehensive approach to managing common post-stroke complications, recognizing that each of these challenges requires both clinical knowledge and a patient-centered mindset. Dysphagia is one of the most immediate concerns, especially in the early stages of recovery due to the risk of aspiration and pneumonia. I routinely perform bedside swallow screens and closely observe for signs such as coughing during meals, wet voice, or pocketing of food. When dysphagia is identified, I promptly collaborate with the Speech and Language Therapy (SLT) team for a full assessment and ensure that patients are placed on appropriate modified diets and fluid consistencies. I also reinforce safe swallowing techniques and maintain strict oral hygiene protocols to reduce infection risk. For communication deficits, including aphasia and dysarthria, I support SLT interventions by using alternative communication strategies, such as visual aids, communication boards, and writing tools, and always speak slowly, clearly, and with patience. I've found it essential to involve family members in communication support, helping them understand how to interact effectively with their loved ones without causing frustration or embarrassment. Motor impairments are a major focus of rehabilitation, and I work closely with physiotherapists to support mobility plans, from assisted transfers to ambulation exercises. I ensure proper positioning to prevent contractures and pressure injuries, and I've been actively involved in using mobility aids and assistive devices to encourage safe independence. Consistent monitoring and documentation of progress help guide adjustments in therapy and care plans. Cognitive deficits, including memory loss, impaired attention, and poor judgment, require continuous observation and reinforcement of routines. I use simple instructions, provide regular orientation cues, like clocks, calendars, and familiar objects, and implement safety measures to prevent accidents or wandering. I've also worked with occupational therapists to help patients relearn daily living skills in a structured step-by-step manner. Emotional lability and mood changes are common and can be distressing for both patients and families. I provide emotional support through active listening and reassurance, and when necessary, I alert the multidisciplinary team for psychological evaluation or medication review. I've found that creating a calm, consistent environment and acknowledging the emotional toll of stroke without judgment makes a meaningful difference in how patients cope. Overall, managing these complications requires a collaborative, proactive, and empathetic approach. I view each challenge not just as a clinical issue to be addressed, but as an opportunity to advocate for the patient's dignity, independence, and quality of life throughout their recovery.
How do you contribute to the interdisciplinary rehabilitation team?
As a stroke rehabilitation nurse, I view my role as an essential part of the interdisciplinary team, contributing both clinical expertise and emotional support to enhance the patient's overall recovery. I actively collaborate with the team, comprising physical therapists, occupational therapists, speech therapists, neuropsychologists, and other specialists, to ensure that each aspect of the patient's rehabilitation is addressed in a holistic, coordinated manner. One of the key ways I contribute is by providing ongoing assessments and updates regarding the patient's physical and neurological status. I monitor changes in motor function, cognition, and emotional health, and share this information with the team to help tailor individualized care plans. For instance, if I notice that a patient is struggling with balance or coordination, I communicate this with the physical therapy team to adjust their therapy sessions accordingly. Similarly, if a patient exhibits signs of dysphagia, I immediately involve speech therapists to assess swallowing function and make necessary dietary adjustments. I also take an active role in patient education and family involvement. I work closely with patients and their families to explain the rehabilitation process, manage expectations, and provide guidance on how they can participate in care at home. By empowering family members with knowledge and skills, I help create a supportive environment for recovery outside the facility. For example, I may instruct family members on safe transfer techniques or on how to assist with exercises that complement physical therapy. Furthermore, I assist in the coordination of care. I attend interdisciplinary team meetings, where I contribute observations and insights from my nursing perspective, ensuring that all interventions align with the patient's medical, physical, cognitive, and emotional needs. I also advocate for the patient's best interests, ensuring that any emerging concerns, whether related to physical health or psychological well-being, are addressed promptly. Finally, I help with psychosocial support by creating a therapeutic and empathetic environment for patients, which is essential when working with individuals facing the emotional challenges of stroke recovery. I liaise with the neuropsychologist to address mood changes, anxiety, or depression, ensuring that emotional health is integrated into the rehabilitation process. In summary, my contributions to the interdisciplinary rehabilitation team are centered around clear communication, collaboration, and a holistic approach to patient care, all of which are critical in maximizing recovery and enhancing the patient's quality of life.
Explain your role in developing and implementing individualized care plans for stroke survivors.
As a stroke rehabilitation nurse, my role in developing and implementing individualized care plans for stroke survivors is central to ensuring that each patient receives care that addresses their unique needs, goals, and progress. I collaborate closely with the interdisciplinary team, including physical, occupational, and speech therapists, neuropsychologists, and physicians, to create a holistic, patient-centered plan that guides the patient's recovery from admission through discharge. The process begins with a thorough assessment of the patient's neurological status, medical history, functional abilities, and any pre-existing conditions that might impact recovery. I assess not only physical aspects like motor function and coordination, but also cognitive, emotional, and social factors, which are crucial for stroke recovery. I ensure that I gather information from both the patient and their family members to understand their goals and concerns, as their input is vital to creating a care plan that is not only medically appropriate, but also meaningful to the patient's daily life. Based on the assessment, I collaborate with the team to set specific, measurable, achievable, relevant, and time-bound, SMART, goals for the patient. These might include regaining motor function, improving speech or swallowing abilities, managing emotional responses, or enhancing cognitive function. Each goal is designed to be realistic based on the patient's condition, but also challenging enough to encourage progress. Once goals are set, I help implement the care plan by coordinating daily nursing interventions, such as monitoring neurological status, administering medications, managing symptoms like pain or spasticity, and assisting with mobility, positioning, and activities of daily living. I also work closely with other team members to ensure that each therapy session, physical, occupational, or speech, aligns with the established goals, adjusting interventions as needed based on patient progress. For example, if a patient shows improvement in motor strength but struggles with balance, I might collaborate with physical therapy to intensify balance exercises while continuing motor rehabilitation. As part of ongoing implementation, I continuously monitor progress and make adjustments to the care plan as the patient's needs evolve. This may involve reassessing the goals or modifying interventions based on new challenges or improvements. I also ensure that patients and their families are fully engaged in the process by providing education about the recovery process, teaching coping strategies, and involving them in goal setting and decision-making. This empowerment is crucial for fostering a sense of ownership in the patient's recovery and ensuring long-term success after discharge. Ultimately, my role in developing and implementing individualized care plans is to ensure that the patient's care is comprehensive, dynamic, and tailored to their unique needs, with the goal of maximizing their functional recovery and quality of life. Collaboration with the broader team and clear communication with patients and families are essential to achieving these goals.
Describe your experience with different assistive devices and technologies used in stroke rehabilitation.
In my experience working in stroke rehabilitation, I have had the opportunity to work with a variety of assistive devices and technologies that play a crucial role in improving patients' functional outcomes and promoting independence. These tools range from simple devices used for daily activities to more advanced technologies that support rehabilitation efforts. I've seen firsthand how the appropriate use of assistive devices can make a significant difference in a patient's recovery journey. One of the most common assistive devices I work with are mobility aids, such as walkers, canes, and wheelchairs. These are essential for helping stroke survivors regain their independence and mobility, especially when motor impairments or balance issues are present. I assist patients in choosing the right mobility aid based on their functional abilities, and I work with the physical therapy team to ensure proper usage to prevent falls and promote safe movement. Orthotic devices, like splints and brace supports, are another integral part of stroke rehabilitation. These devices are used to support weak or paralyzed limbs, maintain joint alignment, and reduce the risk of contractures. I've worked with occupational therapists to properly fit patients for these devices, ensuring that they aid in both function and comfort. I also help with proper skincare under orthotic devices to prevent pressure sores, which are a risk for immobile patients. In terms of more advanced technologies, I have experience using robot-assisted therapy systems, such as exoskeletons and robotic gait trainers. These devices are especially valuable for patients with significant motor impairments or those in the early stages of rehabilitation. They provide repetitive, task-specific exercises that help improve muscle strength, range of motion, and gait patterns. In collaboration with the therapy team, I help ensure that patients are properly positioned and that the technology is used safely to facilitate maximal recovery. Another exciting advancement I've worked with is virtual reality, VR, technology, which has been increasingly used in stroke rehabilitation. VR offers immersive environments that engage patients in simulated tasks, helping improve motor coordination, balance, and cognitive function in a way that feels engaging and motivating. I've seen VR platforms such as graspable and motor imagery software help patients work on specific movements, like reaching or grasping, in a safe and controlled environment. This technology is particularly effective for patients with mild to moderate impairments who need more challenging tasks to improve fine motor skills. For communication deficits, particularly with aphasia or dysarthria. I have worked closely with speech therapists and utilized various augmentative and alternative communication (AC) devices, such as tablet-based communication apps or speech-generating devices. These devices help patients express themselves when they have difficulty with speech production or comprehension, and I ensure patients are trained on their use to maximize their communication abilities. Finally, I've had exposure to monitoring and biofeedback technologies that track patient progress and provide real-time data on metrics like muscle tone, movement patterns, or heart rate. These technologies are particularly useful in assessing progress and fine-tuning rehabilitation plans, allowing the team to adjust therapy in real time. Overall, my experience with assistive devices and technologies in stroke rehabilitation has reinforced the importance of an individualized approach to care. Whether it's helping a patient walk again with a gait trainer, assisting with communication using AAC tools, or supporting cognitive rehabilitation through VR, these technologies can significantly enhance the recovery process and contribute to a patient's overall sense of independence and well-being.
How do you approach bowel and bladder management in stroke patients?
In my role as a stroke rehabilitation nurse, managing bowel and bladder function is a critical aspect of patient care, as stroke can lead to significant impairments in both areas. My approach is both proactive and patient-centered, focusing on restoring function, preventing complications, and enhancing the patient's dignity. When a patient is admitted, I first assess their level of neurological impairment and any related factors, such as sensory deficits or motor weakness, that may affect their ability to control bowel and bladder functions. I also assess the patient's existing bowel and bladder habits, including frequency, urgency, and any previous issues such as incontinence or constipation. This thorough assessment helps me develop an individualized care plan that addresses the specific needs and preferences of each patient. For patients experiencing bladder incontinence, I work closely with the interdisciplinary team to implement a scheduled toileting program. This often involves timed voiding, where patients are encouraged to use the bathroom at regular intervals, even if they do not feel the urge to go. In some cases, I assist with catheter care, ensuring that if an indwelling catheter is necessary, it is managed with the utmost attention to hygiene and comfort to prevent infection. I also educate patients and their families about fluid management and the importance of avoiding overhydration or dehydration, both of which can affect bladder control. For bowel management, I assess the patient's bowel habits and work with dietitians to promote a high-fiber diet and adequate fluid intake. For patients with constipation, I often recommend gentle laxatives or stool softeners, in line with their overall care plan. In cases where there is significant difficulty with bowel movements, I educate patients and families on techniques such as manual disimpaction or using suppositories, always prioritizing patient comfort and dignity. I also advocate for the use of biofeedback or pelvic floor exercises, when appropriate, in collaboration with occupational therapists or physiotherapists. Throughout this process, I maintain open communication with patients and their families, providing education and support to reduce the stigma and emotional discomfort often associated with bowel and bladder dysfunction after a stroke. I empower patients by involving them in their care, setting realistic goals, and offering practical strategies for managing their condition both during hospitalization and after discharge. Above all, my approach to bowel and bladder management in stroke patients is centered on respect and dignity, ensuring that each patient's needs are met while promoting the best possible outcomes. This holistic, compassionate care approach supports not only the patient's physical recovery, but also their emotional and psychological well-being.
Discuss your knowledge of spasticity management post-stroke.
Spasticity is a common and often challenging complication following a stroke, characterized by increased muscle tone and stiffness, which can significantly affect a patient's ability to move, perform daily activities, and maintain independence. Managing spasticity effectively requires a comprehensive, multidisciplinary approach, as spasticity can lead to both functional impairment and discomfort. My knowledge of spasticity management in post-stroke patients involves both preventative measures and targeted interventions, always focused on the individual needs and goals of the patient. Initially, I assessed the severity and location of the spasticity, often using a combination of clinical evaluation and standardized scales, such as the modified Ashworth scale, which helps measure the degree of muscle tone. This allows me to gauge the impact of spasticity on the patient's mobility and function. I also assess for any secondary complications, such as pain, contractures, or skin breakdown, which can result from prolonged muscle stiffness. In terms of non-pharmacological management, I collaborate with physical and occupational therapists to incorporate stretching exercises and positioning techniques that can help manage and reduce spasticity. For example, range of motion exercises are crucial to prevent joint contractures and improve flexibility. I also work closely with therapists to develop a splinting or orthotic regimen for patients with severe spasticity, which can help maintain limb alignment and reduce the risk of deformities. When pharmacological intervention is necessary, I ensure that medications are used in conjunction with physical therapy to address spasticity while minimizing side effects. Oral medications, such as baclofen and tizanidine, are commonly prescribed to reduce muscle tone, and I monitor patients closely for any adverse effects such as sedation or weakness. In cases where oral medications are less effective or when spasticity is localized to specific muscle groups, I support the use of botulinum toxin, Botox, injections. Botox can provide localized relief by blocking the release of neurotransmitters that cause muscle contraction. I collaborate with physicians to determine the appropriate dosage and injection sites to optimize the patient's functional outcomes. For more severe cases, where spasticity interferes with basic care, intrathecal baclofen therapy may be considered. This involves the direct delivery of baclofen to the spinal cord via an implanted pump. I assist in the care and monitoring of patients who undergo this therapy, ensuring that the device is functioning properly and that the patient's response to the treatment is regularly assessed. Finally, I emphasize the importance of patient and family education in managing spasticity. I provide patients and their families with information about the nature of spasticity, the importance of consistent therapy, and practical strategies for preventing complications, such as skin breakdown or discomfort. This education helps empower patients to engage actively in their own care and rehabilitation. Overall, my approach to spasticity management is multifaceted and always personalized, combining evidence-based interventions with a strong focus on patient comfort, safety, and long-term functional goals. By coordinating care across disciplines and ensuring continuous monitoring and adjustment of the management plan, I aim to minimize the impact of spasticity on patients' lives and help them achieve the highest level of independence possible in their post-stroke recovery.
How do you address pain management in stroke rehabilitation?
Pain management in stroke rehabilitation is a critical aspect of patient care, as many stroke survivors experience pain that can stem from a variety of sources, such as muscle spasticity, joint immobility, neuropathic pain, and secondary conditions like pressure ulcers. My approach to pain management is comprehensive, focusing on both pharmacological and non-pharmacological strategies, with an emphasis on individualizing care to meet the unique needs of each patient. The first step in managing pain is a thorough assessment. I start by conducting a detailed pain history, including the onset, location, intensity, and nature of the pain. For stroke patients, I consider potential causes such as musculoskeletal pain from immobility, neuropathic pain, like burning or stabbing sensations, and pain related to spasticity or contractures. I also assess the patient's emotional and psychological well-being, as anxiety and depression can exacerbate the perception of pain. I use both subjective reports from patients and objective observations, such as changes in facial expressions or body language, especially for patients with cognitive impairments who may have difficulty communicating pain effectively. For pharmacological management, I work closely with the medical team to tailor an appropriate pain relief regimen. Non-opioid analgesics, such as acetaminophen and nonsteroidal anti-inflammatory drugs, NSAIDs, are often my first-line options for musculoskeletal or mild nociceptive pain. If the pain is more severe or if the patient is experiencing neuropathic pain, I may support the use of gabapentinoids, e.g., gabapentin or pregabalin, or antidepressants, e.g., amitriptyline, that are effective in treating nerve-related pain. I also ensure that any opioid medications are used judiciously and in conjunction with other modalities to avoid dependency and manage side effects. In cases where spasticity is contributing to pain, I may collaborate with the interdisciplinary team to implement targeted therapies, such as oral medications like baclofen or tizanidine or botulinum toxin, Botox, injections to reduce muscle tone and alleviate pain associated with muscle stiffness. For patients with severe spasticity, I work with physicians to explore intrathecal baclofen therapy, which delivers the medication directly to the spinal cord for more effective pain control. Beyond pharmacological approaches, I emphasize non-pharmacological pain management techniques to complement medical treatments and reduce the need for medications. Physical therapy and occupational therapy play a significant role in addressing pain related to immobility or muscle tightness. For example, I work closely with therapists to implement stretching exercises, range of motion activities, and positioning strategies that help relieve musculoskeletal pain and prevent contractures. Heat and cold therapy are also commonly used to reduce muscle stiffness or inflammation, and I educate patients on their proper application. Cognitive behavioral strategies are another essential component of my approach to pain management. I help patients develop techniques such as relaxation exercises, guided imagery, and distraction techniques to manage pain, particularly in cases where chronic pain is affecting their mood and quality of life. Additionally, I work with the psychological team to address any underlying anxiety or depression that may be amplifying the perception of pain. Finally, I ensure that patient and family education is a key part of pain management. I provide guidance on recognizing the early signs of pain, how to use pain medications appropriately, and the importance of maintaining mobility and participating in rehabilitation to prevent pain from worsening. This educational aspect empowers patients to take an active role in managing their pain, which is crucial for improving long-term outcomes. In summary, my approach to pain management and stroke rehabilitation is holistic and individualized. By combining pharmacological treatments, physical interventions, psychological support, and patient education, I strive to ensure that pain does not hinder a patient's progress in rehabilitation and that they can focus on their recovery and returning to as much independence as possible.
What strategies do you use to promote mobility and prevent falls in stroke patients?
Promoting mobility and preventing falls in stroke patients is a critical aspect of rehabilitation, as these patients are often at high risk for both due to impaired motor function, balance issues, and cognitive deficits. My approach is multifaceted, focusing on early intervention, preventative strategies, and individualized care to improve mobility while minimizing fall risk. From the moment a patient is admitted, I conduct a thorough assessment to evaluate their level of mobility, strength, and balance. This involves observing how they perform basic movements, such as sitting, standing, and walking, and identifying any signs of weakness, spasticity, or coordination deficits. I also assess cognitive function to ensure the patient understands their environment and safety needs, as cognitive impairments such as confusion or poor judgment can contribute to fall risk. Once the assessment is complete, I collaborate closely with the physical therapy team to develop a mobility plan tailored to the patient's specific needs and goals. One of the first strategies I use is to implement early mobilization, which involves assisting the patient with sitting up, transferring to a chair, and engaging in standing and walking activities as soon as it is safe to do so. This early intervention helps maintain muscle strength, prevent complications such as deep vein thrombosis, DVT, and reduce the overall risk of falls by getting the patient accustomed to movement in a controlled, supervised environment. To promote safe ambulation, I ensure that the patient has access to appropriate mobility aids, such as walkers, canes, or gait belts, depending on their level of motor function. I work with physical therapists to ensure that these aids are used correctly, offering both support and stability to the patient while they regain their independence. When appropriate, I encourage partial weight-bearing exercises or use of assistive devices that help improve balance and coordination, making mobility safer and more efficient. Environmental modifications are also key in preventing falls. I assess the patient's environment both in the hospital and at home, ensuring that it is free from obstacles or hazards that could cause tripping. This includes ensuring that floors are clear, ensuring proper lighting, and using non-slip mats or flooring. I also ensure that bed rails and grab bars are appropriately placed in the patient's room, bathroom, and any other areas where they may need additional support. In addition to physical strategies, I incorporate patient and family education into my care plan. I educate patients about the importance of safe mobility practices, such as maintaining proper posture, avoiding sudden movements, and using assistive devices consistently. For example, I instruct patients on how to stand up safely from a sitting position, how to use a walker or cane properly, and how to ask for assistance when needed. I also engage family members in this education, as they play a vital role in supporting the patient's mobility and safety at home. When it comes to preventing falls, I utilize a multidisciplinary approach that includes input from nurses, physiotherapists, occupational therapists, and doctors. I collaborate with the team to monitor and document any changes in the patient's mobility or strength, adjusting care plans and interventions as needed. For patients at high fall risk, I recommend the use of bed alarms or fall monitoring devices, which can alert staff if the patient attempts to stand or move without assistance. For patients with severe spasticity, I work closely with the rehabilitation team to incorporate techniques aimed at reducing muscle tightness and improving range of motion, as these factors often contribute to poor balance and increased fall risk. Botulinum toxin injections or medications like baclofen may be considered in certain cases to reduce spasticity and promote smoother, safer movement. In terms of strengthening, I encourage participation in balance training exercises, such as those that focus on weight shifting, standing on one leg, or walking on uneven surfaces. These exercises not only improve physical strength, but also help patients regain confidence in their ability to move safely. Overall, my strategy to promote mobility and prevent falls in stroke patients is comprehensive, proactive, and patient-specific. It involves a combination of early mobilization, proper use of assistive devices, environmental modifications, education, and ongoing collaboration with the interdisciplinary team. By addressing these aspects, I work to help patients regain their independence, improve their functional mobility, and reduce the risk of falls, ultimately enhancing their quality of life and rehabilitation outcomes.
Describe your understanding of the different stages of stroke recovery: acute, subacute, chronic.
The recovery process after a stroke is dynamic and occurs in distinct stages, each with its own challenges and goals. These stages, acute, subacute, and chronic, represent different phases in the rehabilitation process, and each requires tailored interventions to support the patient's recovery and improve their functional outcomes. Understanding these stages is crucial to providing optimal care and setting realistic expectations for both patients and their families. In the acute phase, which typically occurs in the first 24 to 72 hours following a stroke, the primary focus is on stabilization and medical management. During this stage, the patient is usually in the intensive care unit, ICU, or a specialized stroke unit, where the medical team works to prevent complications such as swelling in the brain, further stroke, and other acute issues like respiratory distress or cardiac events. The neurological assessment is critical at this stage, as I carefully monitor for signs of neurological deterioration, such as changes in consciousness, pupil response, or motor function. This stage is also about beginning early rehabilitation to minimize the impact of impairments. Although the patient may be severely impaired, with some patients unable to move or communicate, rehabilitation efforts begin with basic passive range of motion exercises and positioning to prevent complications like pressure sores or muscle contractures. If the patient is stable enough, Early mobilization strategies are introduced to prevent complications like deep vein thrombosis, DVT, and promote circulation. Family education starts during this phase, providing them with information about the stroke, its potential outcomes, and the importance of early rehabilitation. In the subacute phase, which typically spans from a few days to a few weeks after the stroke, the focus shifts to intensive rehabilitation aimed at improving functional abilities. Patients are usually transferred to a stroke rehabilitation unit or inpatient rehabilitation center, where the interdisciplinary team, comprising physical therapists, occupational therapists, speech therapists, and nurses, work collaboratively to address the patient's deficits. At this stage, active rehabilitation becomes a priority. For example, physical therapy focuses on improving mobility, strength, and coordination, while occupational therapy works on fine motor skills, activities of daily living, ADLs, and cognitive rehabilitation. Speech therapy addresses any communication deficits, such as aphasia or dysarthria, and dysphagia, difficulty swallowing, which can be a significant concern in the subacute stage. This phase is also when patients may begin to experience significant neurological recovery, particularly in the first few weeks. The brain has some degree of plasticity, meaning it can adapt and rewire itself to compensate for lost functions, especially when rehabilitation is started early. However, progress during this phase can be variable depending on the extent of brain injury, the stroke's location, and the patient's overall health. As a nurse, I focus on managing medical complications such as pain, spasticity, and swallowing difficulties, and facilitating ongoing rehabilitation exercises. I also assist in the transition to outpatient or home-based care if the patient is ready for discharge. The chronic phase begins several months after the stroke, often marked by the stabilization of medical conditions and the shift toward long-term recovery. This phase can last for years, and while progress can still occur, it is usually slower and more gradual compared to the earlier stages. Patients may experience some residual deficits, such as weakness, imbalance, or cognitive issues, and the focus of rehabilitation now moves to maintaining and enhancing independence. In the chronic stage, I collaborate with the team to develop an individualized maintenance plan that includes outpatient therapy, home exercises, and ongoing psychological support. This phase also involves preventing secondary complications like depression, fatigue, and musculoskeletal deformities, e.g., contractures or pressure sores. Additionally, patients in the chronic phase may face the challenge of reintegration into their communities and daily life, where the goal is not necessarily to regain normal function, but to achieve the highest level of independence possible. Assistive devices and adaptive technologies may become more integrated into the patient's routine, and caregivers are essential in supporting the patient's ability to live independently. I work closely with both patients and their families to ensure they have the resources and knowledge to continue managing the effects of the stroke in a sustainable way. Each stage of recovery requires a nuanced approach to care, with interventions tailored to the patient's specific needs at the time. Understanding the progression from the acute phase, where immediate medical care and stabilization are paramount, through to the subacute and chronic phases, where rehabilitation and long-term support play a major role, allows me to provide comprehensive care that promotes the patient's recovery and overall quality of life.
How do you educate patients and their families about the recovery process, potential challenges, and strategies for long-term management?
Educating patients and their families about the recovery process after a stroke is a crucial part of rehabilitation. It empowers them with the knowledge and skills needed to manage their care, navigate challenges, and make informed decisions about treatment options and lifestyle adjustments. My approach to education is holistic, tailored to the individual's specific needs, and delivered in a compassionate, clear, and supportive manner. From the very beginning of the recovery process, I establish a collaborative relationship with the patient and their family. I start by explaining the stroke recovery process in stages: acute, subacute, and chronic, emphasizing that recovery is a gradual and ongoing journey. I stress that each person's recovery path will be unique, influenced by factors such as the type, location, and severity of the stroke, as well as the patient's overall health and rehabilitation efforts. In the acute and subacute phases, I focus on helping the patient and family understand the immediate needs of stroke recovery. This includes providing information about the importance of early rehabilitation and mobilization, explaining potential complications such as pain, swallowing difficulties, or spasticity, and discussing the role of medication and medical management in preventing further strokes or complications. I also emphasize the importance of emotional support during these phases, as patients and families may experience a range of emotions, from fear and frustration to confusion and depression. I encourage open communication with both the healthcare team and each other, as this fosters a supportive environment for recovery. I use visual aids, such as charts and diagrams, and provide written materials to reinforce verbal explanations, recognizing that stroke patients may have difficulty processing information at times, especially if they have cognitive impairments. For example, I explain the rehabilitation therapies the patient will undergo, physical, occupational, and speech therapies, and help the family understand their role in supporting these therapies at home. In the chronic phase, education shifts to long-term management. I work closely with the patient and family to discuss strategies for maintaining independence and preventing complications. This might include teaching the patient techniques for managing muscle spasticity, pain, and swallowing difficulties if they persist. I educate on strategies for improving mobility, such as home exercises, assistive devices, and fall prevention. Family members are shown how to assist with activities of daily living, ADLs, including dressing, grooming, and feeding, especially if the patient is still experiencing limitations in motor function. In addition to physical management, I discuss the psychological aspects of stroke recovery. Patients and families need to understand that it is common to experience emotional changes, such as depression, anxiety, and mood swings, as a result of the stroke itself and the recovery process. I encourage patients and families to seek support from psychologists, counselors, or support groups, if needed, to address these issues. I place significant emphasis on nutrition, exercise, and lifestyle changes as part of the long-term management plan. I discuss how a healthy diet can help manage blood pressure and prevent future strokes, and how regular exercise can improve strength, mobility, and mental health. For patients with risk factors for stroke, such as hypertension, diabetes, or hyperlipidemia, I reinforce the importance of medication adherence and regular follow-up appointments with their healthcare providers. I also offer resources for smoking cessation, weight management, and stress reduction, all of which contribute to long-term health. For family members, I provide guidance on caregiving and self-care, as they often take on significant roles in the patient's recovery. I educate them about the challenges they might face, such as caregiver burnout, and suggest strategies for balancing caregiving with personal well-being. This might involve suggesting respite care, organizing a support network, or seeking professional help when necessary. To ensure that the information is understood and that the patient and family feel confident in managing recovery, I encourage ongoing communication and follow-up education. As the patient progresses in their recovery, I provide regular check-ins to assess their needs and adjust the care plan. I reinforce key concepts, answer any questions, and offer additional resources, ensuring they feel empowered to navigate the challenges ahead. In summary, my approach to educating patients and their families is comprehensive, compassionate, and tailored to each individual's needs. By providing clear, actionable information, offering emotional support, and fostering an open line of communication, I aim to equip both the patient and their family with the knowledge, tools, and confidence necessary for a successful long-term recovery.
How do you establish rapport and build trust with patients who may be frustrated, emotionally labile, or have communication difficulties following a stroke?
Building rapport and establishing trust with patients who are emotionally labile, frustrated, or have communication difficulties following a stroke requires a combination of empathy, patience, and clear, consistent communication. I recognize that these patients may be dealing with significant emotional, physical, and cognitive challenges and my approach focuses on creating a safe, supportive, and respectful environment where they feel heard and valued. When working with stroke patients who may be frustrated or experiencing emotional lability, I first take the time to listen actively. I acknowledge their emotions without judgment, offering verbal and nonverbal cues that show I am present and attentive. For example, if a patient is expressing frustration due to a physical limitation or inability to communicate effectively, I calmly reassure them that these feelings are normal and a part of the recovery process. I use a calm and soothing tone of voice to help de-escalate any heightened emotions, providing reassurance and hope that recovery, although challenging, is possible. I also take the time to explain their condition and the rehabilitation process in a clear, simple manner, tailoring my communication to their level of understanding. For patients with communication difficulties, such as aphasia or dysarthria, I use alternative communication methods, such as visual aids, gestures, or picture boards, to facilitate understanding. I make sure that I give the patient ample time to respond, showing patience and ensuring that they do not feel rushed or pressured to communicate before they are ready. This patience is key to building trust, as patients who feel that they are being listened to and given the time they need often feel more in control of their situation. In addition, I strive to involve the patient in their care decisions as much as possible. This includes giving them choices and encouraging their input in the treatment plan, even if it means using simple yes/no questions or employing communication tools. This approach fosters a sense of empowerment, allowing the patient to feel more involved and less helpless. I find that when patients feel they have some control over their recovery, their frustration levels tend to decrease, and their engagement in the rehabilitation process increases. Building trust with family members is also a crucial part of this process. Families often experience their own frustration and anxiety about their loved one's recovery, and I make sure to keep them informed and involved in the care plan. I provide them with resources and support, helping them understand the emotional and psychological impacts of stroke recovery. This not only supports the patient, but also strengthens the overall therapeutic relationship and ensures a collaborative approach to care. Finally, I always maintain a consistent presence and approach to care. Stroke recovery can be unpredictable, and patients may have good days and bad days, but my consistent, compassionate approach helps build trust over time. I make it a point to check in with patients regularly, offer emotional support, and celebrate even the smallest successes, reinforcing the idea that progress is being made, even when it may not always be immediately visible. In summary, I establish rapport and build trust with stroke patients by being patient, empathetic, and adaptive in my communication. I ensure that patients feel heard and understood, providing them with the time, tools, and support they need to navigate their recovery. This holistic, respectful approach helps reduce frustration, build trust, and ultimately supports the patient's overall rehabilitation journey.
Describe your experience in communicating with families and caregivers of stroke survivors. How do you provide them with support and education?
In my experience working with stroke survivors, communicating with families and caregivers is a critical aspect of the rehabilitation process. Families and caregivers often face emotional, physical, and logistical challenges as they adjust to the new dynamics following a stroke, and it's important to provide them with both the information and emotional support they need to navigate this journey. My approach involves being a source of consistent guidance, education, and reassurance, ensuring that families feel empowered and equipped to support their loved ones effectively. At the outset, I take the time to meet with the family members to explain the stroke survivor's condition and prognosis in a way that is clear, realistic, and compassionate. This initial conversation is crucial because it helps manage expectations and provides families with a framework for understanding the recovery process. I address common concerns, such as the potential for physical or cognitive impairments, and explain the rehabilitation stages, acute, subacute, and chronic, so that the family can understand the long-term nature of recovery. I make sure to provide this information in a patient-friendly language, avoiding medical jargon to ensure that the family feels confident and clear about the process. Throughout the recovery journey, I ensure that families are kept informed and involved in the patient's care. I provide them with regular updates on their loved one's progress, including any changes in their condition, and encourage open lines of communication. I believe that family involvement not only helps with decision-making, but also fosters a sense of shared responsibility for the patient's recovery. I invite family members to attend therapy sessions when appropriate, allowing them to witness firsthand the strategies and techniques being used in rehabilitation. This empowers them with the knowledge and skills they need to assist in activities of daily living, ADLs, or mobility exercises at home. One of the most important aspects of communicating with families is providing emotional support. I recognize that stroke recovery can be a challenging and emotionally taxing experience for caregivers. I offer a listening ear, validate their feelings, and acknowledge the difficulty of the situation. It is essential to build trust so that family members feel comfortable sharing their own frustrations, fears, or concerns. I encourage them to take care of their own emotional and physical well-being as well. Caregivers often experience burnout, so I make sure to highlight the importance of self-care and suggest respite care or support groups where they can find additional resources and emotional support. I also provide ongoing education to families about specific caregiving tasks, such as managing mobility aids, assisting with feeding, dressing, or helping the patient with swallowing difficulties. I teach them techniques to ensure proper body mechanics when assisting the patient with transfers or ambulation, and I reinforce the importance of maintaining a safe environment to prevent falls. Additionally, I educate families about managing spasticity, pain, and any other physical issues the stroke survivor may encounter. I show them how to perform certain range of motion exercises or stretching routines to help the patient maintain mobility and prevent complications like contractures. As part of ongoing education, I also focus on teaching families about the psychological aspects of stroke recovery. Stroke survivors may experience mood swings, depression, or anxiety as part of their recovery process, and caregivers need to understand these potential changes. I explain that emotional lability and frustration are common after a stroke and provide coping strategies to help families manage these fluctuations in mood. I also emphasize the importance of cognitive rehabilitation and provide suggestions for engaging the patient in activities that promote cognitive function, such as memory exercises or problem-solving tasks. Moreover, I equip families with community resources and support networks, such as stroke survivor groups or counseling services, to help them connect with others who are experiencing similar challenges. Having a support system can be immensely beneficial in reducing isolation and providing encouragement as they navigate the complexities of caregiving. In summary, my approach to communicating with families and caregivers of stroke survivors involves a combination of education, emotional support, and practical guidance. By providing clear and ongoing information, actively listening to their concerns, and offering resources to assist them in their caregiving role, I help ensure that families are well prepared and supported throughout the recovery process. This holistic approach not only enhances the stroke survivor's rehabilitation experience, but also strengthens the family's ability to provide long-term care.
How do you advocate for the needs and goals of your patients within the rehabilitation team?
Advocating for the needs and goals of my patients within the rehabilitation team is an essential part of my role as a nurse in stroke rehabilitation. I believe that effective advocacy involves not only ensuring that the patient's voice is heard, but also facilitating a collaborative environment where all members of the rehabilitation team can work together to tailor the best possible care plan for each patient. My approach is rooted in clear communication, active listening, and a patient-centered mindset. First, I start by getting to know my patients thoroughly, understanding their medical history, their specific stroke-related impairments, their personal goals, and any cultural, emotional, or psychological factors that may influence their rehabilitation. I take time to listen to the patient's concerns, preferences, and aspirations, ensuring that I understand what they hope to achieve throughout their recovery. Whether it's regaining the ability to walk, improving communication skills, or returning to activities of daily living, ADLs, I make sure these goals are not only noted but prioritized in their care plan. Once I have a clear understanding of the patient's needs and goals, I advocate for them during team meetings by bringing these considerations to the forefront. I actively participate in interdisciplinary team discussions, which often involve physical therapists, occupational therapists, speech therapists, neuropsychologists, and doctors. During these meetings, I make sure to highlight any concerns the patient might have about their rehabilitation process and offer suggestions for adjustments to the treatment plan that align with their individual goals. For example, if a patient is particularly focused on regaining independence and mobility, I ensure that the physical therapy goals are specifically designed to address this, while also considering any other medical factors that might be limiting their progress, such as pain or spasticity. An important part of advocating for my patients is ensuring that their emotional and psychological needs are acknowledged. Many stroke survivors experience depression, anxiety, or frustration during their recovery, which can significantly impact their rehabilitation progress. If I notice that these emotional aspects are affecting the patient's engagement in therapy, I advocate for psychological support, such as counseling or group therapy, and ensure that the team takes these factors into account when designing the care plan. I often initiate conversations with the team about behavioral changes, mood fluctuations, or cognitive impairments, advocating for interventions that are not just physical, but also emotional and psychological. In addition to verbal advocacy, I also take a hands-on approach to ensuring that the patient's goals are met by regularly monitoring their progress and providing feedback to the team. If I observe that a patient is struggling with a particular aspect of their rehabilitation, I immediately communicate this to the relevant team members and work together to adjust the approach. For example, if a patient is having difficulty with swallowing and therapy is not yielding expected results, I would consult the speech therapist to explore alternative strategies or interventions that might be more effective. By staying in close communication with the team and keeping detailed records, I ensure that any changes in the patient's condition are addressed promptly. Furthermore, I ensure that the family is included in the advocacy process. Often, families have valuable insights into the patient's needs and goals, which may not always be communicated during team meetings. I encourage family members to share their observations and concerns, and I relay this feedback to the rehabilitation team. By involving the family in the care process, I create a unified approach that is not only centered on the patient, but also includes those who are most intimately involved in their day-to-day care. Finally, I advocate for patient autonomy in decision-making. It is important to respect the patient's wishes and preferences, especially in the context of rehabilitation goals. If a patient wishes to pursue a certain goal that might not be in line with traditional therapy expectations, such as returning to work or participating in a hobby despite physical limitations, I ensure that these desires are integrated into the rehabilitation plan. I help the patient understand the realistic outcomes of their goals, but also work with the team to make those aspirations a feasible part of the recovery process, focusing on what the patient can achieve and how we can support them in reaching those milestones. In summary, advocating for my patients within the rehabilitation team involves actively listening to their needs and goals, communicating effectively with the team, adjusting care plans based on progress and challenges, and ensuring that the patient's voice is heard throughout the rehabilitation process. I prioritize a holistic, patient-centered approach, working to ensure that both physical and emotional needs are addressed and that the rehabilitation goals are truly aligned with what matters most to the patient.
How do you incorporate patient and family preferences into the care plan?
Incorporating patient and family preferences into the care plan is fundamental to providing individualized, person-centered care in stroke rehabilitation. I believe that both the patient and their family are key collaborators in the recovery process, and their input not only helps shape the care plan, but also fosters a sense of empowerment and engagement. My approach to incorporating their preferences is rooted in active communication, respect, and flexibility. The first step in incorporating patient and family preferences is establishing an open and trusting line of communication. I make it a priority to engage in discussions with both the patient and their family from the very beginning of the rehabilitation process. This involves creating a space where they feel comfortable sharing their thoughts, concerns, and goals. I ask open-ended questions to better understand the patient's values, aspirations, and cultural considerations, as these factors often play a significant role in the patient's approach to recovery. For example, I might ask, what are the most important things you'd like to regain during your recovery? Or what are your primary concerns as we work together on your rehabilitation plan? Once I've gathered this information, I incorporate it into the care plan by aligning the rehabilitation goals with the patient's priorities. If a patient expresses a strong desire to return to work or participate in social activities, I ensure that these goals are included in the care plan, alongside the more typical rehabilitation goals such as mobility or speech recovery. If the family mentions concerns about the patient's emotional well-being or the need for more support at home, I work with the interdisciplinary team to address these issues, such as recommending psychological support, caregiver education, or respite care. Another important aspect is respecting the patient's autonomy in decision-making. I acknowledge that recovery can be a difficult and complex process, and it's essential to involve the patient in making informed decisions about their care. I discuss the available options, explain the pros and cons, and, when appropriate, offer the patient choices about their treatment. For example, if a patient is struggling with mobility, I would discuss different types of assistive devices and their benefits, allowing the patient to choose what feels most comfortable and empowering to them. By offering choices and discussing options, I ensure that the patient has a sense of control over their recovery, which can improve both motivation and engagement. When working with families, I take care to ensure that their perspectives and needs are also considered. Caregiving can be emotionally and physically demanding, and family members often have valuable insights into the patient's daily needs. I involve them in care planning discussions by asking about their preferences for the patient's living environment, daily routines, and how they can best assist with rehabilitation at home. If the family expresses concerns about managing the patient's physical therapy exercises or daily activities, I provide education and training on how they can assist safely and effectively, ensuring that their involvement is both supportive and sustainable. I also recognize that cultural preferences and beliefs play a significant role in shaping a patient's recovery. If the patient or family has specific cultural or religious beliefs that affect their care, such as preferences for certain types of treatment, diet, or even visitation during rehabilitation, I ensure that these are respected and incorporated into the care plan where possible. I ask open, respectful questions to understand these preferences and collaborate with the team to adapt the care plan to meet the patient's cultural needs without compromising clinical outcomes. In practice, I incorporate patient and family preferences by continuously assessing and adjusting the care plan based on feedback and progress. I hold regular check-ins with the patient and family to review how the rehabilitation process is unfolding and whether their needs or goals have changed. If a goal is not being met or if the patient's preferences evolve, I work with the team to make any necessary adjustments to the care plan. This flexibility allows the patient and family to feel that their voices are always heard and that their concerns are being addressed in real time. In summary, incorporating patient and family preferences into the care plan requires active listening, respectful communication, and a commitment to ensuring that the care plan reflects the individual needs, values, and aspirations of both the patient and their family. By making them active participants in the process, I can create a personalized care plan that is not only clinically sound, but also supportive of the patient's long-term recovery and well-being.
How do you address the psychological and emotional impact of stroke on both the patient and their family?
Addressing the psychological and emotional impact of stroke on both the patient and their family is a crucial component of stroke rehabilitation. As a nurse, I recognize that stroke not only affects the body, but also profoundly impacts the mind and emotions. Patients often face a range of emotions, including frustration, sadness, anxiety, and fear, as they cope with significant changes to their health, abilities, and independence. Families, too, experience emotional strain as they support their loved one through recovery. My approach focuses on providing both emotional support and practical guidance, creating an environment where patients and families feel understood, empowered, and supported in managing these challenges. For patients, I start by acknowledging the emotional and psychological aspects of their recovery. Stroke survivors often experience feelings of loss, particularly related to their independence, mobility, or cognitive function. I spend time listening to their concerns and fears, creating a safe space where they can express their emotions without judgment. This can be particularly important for patients dealing with depression, anxiety, or post-stroke emotional lability, mood swings. For example, if a patient is feeling overwhelmed by their inability to return to normal activities, I validate their feelings and reassure them that these emotions are a normal part of the recovery process. I help them set realistic, achievable goals to regain some sense of control over their lives. This could include simple tasks like feeding themselves or being able to engage in light physical activities. I emphasize the importance of celebrating small victories and progress, which can significantly boost the patient's self-esteem and motivation. In addition to providing emotional support, I ensure that patients have access to mental health resources. Many stroke survivors may experience depression, and I monitor for signs of mood disturbances. If necessary, I work with the interdisciplinary team to recommend psychological support, such as therapy or counseling, and I make sure the patient is aware of available resources like stroke survivor support groups, where they can connect with others who understand their experience. I believe that peer support is incredibly valuable for emotional healing, as it can reduce feelings of isolation and encourage patients to share coping strategies. For patients with communication difficulties, such as aphasia or dysarthria, I take extra care in ensuring that they feel heard. Communication is a critical aspect of emotional expression, and when patients struggle to communicate, it can lead to feelings of frustration, isolation, or even anger. I use alternative communication tools, such as picture boards, writing, or simple yes/no questions, to help the patient express their thoughts and feelings. I also work closely with speech therapists to ensure that the patient receives the appropriate treatment to help them improve their ability to communicate over time. When it comes to supporting families, I understand that they, too, experience significant emotional and psychological challenges as they adjust to the stroke survivor's needs. Family members often face caregiver stress, anxiety about the patient's recovery, and feelings of helplessness. I make it a priority to engage with the family early on, educating them about the emotional effects of stroke recovery and providing them with coping strategies to manage the stress and emotional burden they may face. This could include suggestions for time management and self-care, as caregivers often neglect their own needs while focusing on their loved one's care. I also recognize the importance of helping families manage expectations. Many families hope for rapid improvement, but stroke recovery is often a long and unpredictable process. I guide them through understanding the stages of recovery, acute, subacute, and chronic, and the challenges they may encounter at each stage. This helps reduce frustration when progress is slower than expected and allows families to celebrate the small successes along the way. Another key aspect is involving families in the care process. Stroke recovery is a team effort, and families play a critical role in rehabilitation. I encourage them to participate in therapy sessions, whether by assisting with physical exercises, supporting speech therapy activities, or learning techniques to assist with activities of daily living. This involvement not only fosters a sense of purpose for the family members, but also strengthens their bond with the patient. Furthermore, I provide families with resources on support groups, caregiver education, and respite care, which can help alleviate stress and offer emotional support. Connecting families with these resources helps them feel less isolated and more empowered in their caregiving role. In summary, addressing the psychological and emotional impact of stroke on both patients and their families requires a compassionate, patient-centered approach. I focus on providing emotional support, practical guidance, and access to mental health resources for patients, while also offering education, coping strategies, and caregiver support for families. By creating a collaborative, empathetic environment, I help both the patient and their family navigate the emotional challenges of stroke recovery, ultimately improving their well-being and enhancing the rehabilitation process.
Describe a time you had to adapt your communication style to meet the needs of a patient with cognitive or communication deficits.
In my experience, adapting my communication style to meet the needs of a patient with cognitive or communication deficits is often essential in providing effective care. One specific instance that stands out was when I worked with a stroke patient who had developed aphasia as a result of a left hemisphere stroke. This condition significantly impaired their ability to speak and understand language, making communication extremely challenging. The patient was frustrated because they could not express themselves as easily, and this frustration was compounded by the emotional toll of the stroke. Initially, I realized that the usual verbal communication methods were not effective, and the patient's frustration was increasing. I needed to adjust my approach to ensure that the patient felt heard and respected, while also helping them engage in their rehabilitation process. First, I made a conscious effort to remain patient and calm, recognizing that communication difficulties can lead to emotional distress. I slowed down my speech and used simple, clear language while also using nonverbal cues such as gestures and facial expressions to support understanding. For instance, I would point to objects or actions to reinforce what I was saying, and I also used visual aids, like picture cards or a whiteboard, which the patient could point to in order to communicate their needs or responses. Another key adaptation was to involve the family in the communication process. The patient's spouse was present during several of our sessions, and they knew the patient well, including how they might try to convey certain thoughts despite the aphasia. I worked closely with the spouse to help interpret some of the nonverbal cues or fragmented speech the patient used. This collaboration not only improved our ability to understand each other, but also helped build the patient's confidence, as they could see that their family member was actively involved in their care and communication. When it came to tasks such as assisting with daily activities or therapy exercises, I used visual demonstrations and hand-over-hand guidance. For example, when I was assisting with a mobility exercise, I would demonstrate the action slowly while the patient observed. Then I would gently guide their movements, allowing them to participate even if they couldn't verbally respond or fully follow instructions. This hands-on approach helped the patient feel more engaged and gave them a sense of accomplishment, despite their communication challenges. I also made sure to be receptive to their attempts at communication, no matter how small. If the patient struggled to say a word, I would offer a couple of options for them to choose from or give them the opportunity to point at pictures or objects. This approach respected their dignity and helped reduce any anxiety they felt about their inability to communicate effectively. One of the most rewarding moments came when, after a few weeks of using these strategies, the patient began to use a communication board to indicate their preferences. Though verbal communication was still a challenge, they were able to successfully communicate some basic needs, such as requesting assistance with physical therapy or asking for specific food choices. This small success was a huge boost to both the patient's morale and the family's sense of involvement in the rehabilitation process. Ultimately, adapting my communication style with this patient required me to be creative, flexible, and highly attuned to their individual needs. It was not just about finding ways to convey information, but also about ensuring that the patient felt empowered and valued, despite the limitations imposed by their cognitive and communication deficits. This experience reinforced the importance of being patient-centered in my communication and recognizing that different patients require different approaches. Whether through the use of visual aids, gestures, family involvement, or simply allowing extra time for communication, it is crucial to adjust my style in a way that makes the patient feel heard and understood, which in turn enhances their confidence and involvement in their recovery.
What are the key principles of neuroplasticity, and how do you incorporate them into your nursing care?
Neuroplasticity is the brain's remarkable ability to reorganize itself by forming new neural connections in response to injury, learning, or changes in the environment. This process is particularly relevant in stroke rehabilitation, as the brain attempts to compensate for damaged areas by utilizing undamaged regions. Understanding and incorporating the principles of neuroplasticity into my nursing care is essential for promoting recovery and enhancing the rehabilitation process. One of the key principles of neuroplasticity is repetition. The brain strengthens neural pathways through repeated practice of specific tasks. In stroke rehabilitation, I ensure that my patients are engaged in consistent, repetitive exercises that target the motor skills, cognitive abilities, or speech functions that have been affected by the stroke. For example, I work closely with physical and occupational therapists to ensure that the patient is performing exercises regularly and correctly, whether it's practicing walking, fine motor tasks, or cognitive exercises. By promoting this kind of repetition, I support the brain's ability to form new connections and improve functional outcomes. Another important principle of neuroplasticity is intensity. For neuroplasticity to be effective, the intensity of the exercises and interventions must be sufficient to stimulate the brain and encourage remodeling. I incorporate this principle into my care by adjusting the intensity of the rehabilitation activities according to the patient's tolerance and progress. If a patient is able to tolerate more frequent or more challenging tasks, I collaborate with the interdisciplinary team to gradually increase the intensity, ensuring that the rehabilitation process remains challenging without overwhelming the patient. This progressive increase helps to push the brain to adapt and rewire itself in a way that promotes optimal recovery. The principle of task-specific training also plays a vital role in neuroplasticity. The brain responds best to exercises that are closely aligned with the patient's functional goals. If a stroke patient's primary goal is to regain the ability to feed themselves, I collaborate with occupational therapists to ensure that the exercises and activities are tailored to this task. I help patients practice tasks that mimic daily activities, as the brain is more likely to form effective connections when the exercises are meaningful and directly related to the patient's needs. This task-specific training can be more motivating for the patient as they see tangible improvements in their ability to engage in daily life. Motivation and engagement are also critical factors in neuroplasticity. A motivated patient is more likely to engage in the rehabilitation process and put in the effort required for neuroplastic changes to occur. I work to create an encouraging environment that fosters motivation by setting achievable goals, celebrating small successes, and providing positive reinforcement. I also ensure that the rehabilitation process is patient-centered, allowing the individual to focus on what is important to them, whether it's returning to work, improving independence, or engaging in social activities. When patients feel that their goals are respected and that they are making progress, they are more likely to stay committed to the rehabilitation process. Lastly, early intervention is crucial in harnessing the power of neuroplasticity. The brain's ability to adapt is strongest in the initial phases of recovery, so I prioritize early and aggressive rehabilitation interventions. As soon as the patient is stable enough, I collaborate with the team to implement a tailored rehabilitation plan that stimulates neuroplasticity as early as possible. This may involve working on motor, speech, or cognitive tasks right from the acute phase of recovery to take advantage of the brain's heightened ability to reorganize. Incorporating these principles of neuroplasticity into my nursing care involves not only facilitating the physical aspects of rehabilitation, but also creating a holistic, supportive environment that encourages repetition, intensity, task-specific training, motivation, and early intervention. By understanding and applying neuroplasticity, I can contribute to maximizing recovery outcomes and helping patients regain independence and quality of life after a stroke.
Discuss the importance of early and intensive rehabilitation in stroke recovery.
Early and intensive rehabilitation plays a pivotal role in stroke recovery, as it significantly influences the long-term outcomes and the extent to which a stroke survivor can regain their independence and quality of life. Research and clinical experience consistently highlight that the sooner rehabilitation begins, the more effective it tends to be. Early intervention leverages the brain's natural capacity for neuroplasticity, which allows it to reorganize and form new connections to compensate for the areas of the brain that were affected by the stroke. This is why initiating rehabilitation as early as possible, ideally within the first few days to weeks after the stroke, is critical to maximizing recovery potential. One of the primary reasons early and intensive rehabilitation is essential is that it helps to prevent or minimize secondary complications. After a stroke, patients often face a range of challenges, including immobility, muscle weakness, and joint contractures due to prolonged inactivity. If rehabilitation is delayed, these issues can become more entrenched, making it harder for the patient to regain function later on. By starting rehabilitation early, we can address these problems before they become more severe. For example, early mobility exercises can help prevent muscle atrophy and deep vein thrombosis, while encouraging the patient to move regularly can also reduce the risk of pressure sores. Another reason early rehabilitation is vital is the potential to take advantage of the brain's plasticity during the acute and subacute phases of recovery. Neuroplasticity is most effective when rehabilitation starts shortly after the stroke, as the brain is more malleable during this period. Intensive therapy during this time promotes the reorganization of neural pathways and encourages the brain to form new connections, which can help restore lost functions. Whether it's motor skills, cognitive abilities, or speech functions, early and intensive therapy can lead to better outcomes in regaining these abilities, especially when interventions are tailored to the individual's specific needs and goals. Intensive rehabilitation also accelerates functional recovery. Stroke survivors can experience significant improvements in their physical and cognitive abilities when they are consistently engaged in therapy. When rehabilitation is intensive, meaning that it involves frequent, repetitive sessions with a variety of therapeutic techniques, patients are more likely to achieve quicker gains. For instance, a patient recovering from a motor impairment due to a stroke might benefit from intensive physical therapy that involves repetitive, task-specific training, which can help the brain relearn how to control movements and improve motor function. The sooner this training is implemented, the more effective it will be in helping the patient regain independence and perform activities of daily living. Moreover, intensive rehabilitation also addresses the psychosocial aspects of recovery. After a stroke, many patients experience depression, anxiety, or post-stroke emotional lability as a result of the sudden changes to their physical and cognitive abilities. Early intervention, particularly involving a multidisciplinary team, provides not only physical rehabilitation but also psychological support. This support helps the patient understand their condition, adjust to their new reality, and develop coping mechanisms. When rehabilitation includes psychological and emotional support early in the recovery process, it can reduce the emotional burden that often accompanies stroke recovery and can motivate the patient to stay committed to their rehabilitation goals. In addition to the patient's recovery, early and intensive rehabilitation also benefits families and caregivers. Stroke recovery can be a long and challenging process, and the sooner families and caregivers are educated and involved, the better they can support their loved one. Early intervention programs typically involve family members in the rehabilitation process, teaching them how to assist with exercises, monitor progress, and provide emotional support. This early involvement helps families manage expectations, reduce stress, and be better equipped to care for the patient once they are discharged from the rehabilitation facility. Finally, early rehabilitation allows for better long-term outcomes. Studies have shown that the first 6 months following a stroke are critical for recovery, as patients tend to experience the most significant improvements during this period. Intensive rehabilitation during this window increases the likelihood of maximizing the recovery potential and reduces the risk of permanent disability. When rehabilitation is initiated promptly, stroke survivors are more likely to achieve functional independence, leading to better overall outcomes in terms of mobility, self-care, and participation in community activities. In summary, early and intensive rehabilitation is crucial in stroke recovery for a variety of reasons. It helps prevent secondary complications, maximizes the brain's neuroplasticity, accelerates functional recovery, and provides both the patient and their family with the emotional and psychological support necessary for a successful recovery journey. By initiating rehabilitation as soon as possible and ensuring that it is intensive, we can significantly improve the chances of a positive outcome and enable stroke survivors to regain as much independence and quality of life as possible.
Discuss the importance of early and intensive rehabilitation in stroke recovery.
Promoting independence and self-management skills in stroke survivors is a fundamental aspect of stroke rehabilitation, as it helps patients regain control over their lives and enhances their quality of life. As a nurse, I believe that fostering independence involves a combination of tailored care plans, empowerment strategies, and continuous support. I approach this process with a patient-centered focus, ensuring that the rehabilitation goals are not only aligned with the clinical needs of the patient, but also respect their personal aspirations and values. One of the most effective ways to promote independence is through goal setting. Early on, I work with each stroke survivor to identify realistic and meaningful goals that are aligned with their values and lifestyle. These goals may range from physical milestones, such as walking unassisted or performing activities of daily living, ADLs, like dressing or feeding themselves, to cognitive or emotional goals, such as regaining the ability to manage their medications or returning to work. By setting clear, achievable goals, patients can see progress over time, which builds their confidence and motivates them to take an active role in their rehabilitation. I also ensure that these goals are regularly reviewed and adjusted based on the patient's progress, which helps to maintain a sense of accomplishment and encourages continued effort. In addition to goal setting, I focus on teaching and empowering patients with the tools they need to manage their own care. This includes educating stroke survivors on their condition, the rehabilitation process, and the importance of self-care. I provide clear instructions on how to perform specific exercises, manage medications, and monitor for signs of complications, such as pressure sores or changes in blood pressure. I also encourage patients to take responsibility for their health by teaching them strategies for managing chronic conditions like hypertension or diabetes, which can influence stroke recovery. Empowering patients with knowledge allows them to make informed decisions about their care and fosters a sense of ownership over their recovery. Another key strategy is adaptive techniques and the use of assistive devices. Stroke survivors often face challenges with mobility, communication, and daily tasks due to physical or cognitive impairments. By teaching patients how to use assistive devices, such as wheelchairs, walking aids, or adaptive utensils, I can help them regain independence in their daily activities. I also collaborate with physical, occupational, and speech therapists to ensure that the patient is trained in the use of these devices and techniques. For example, if a patient has difficulty with fine motor tasks, I might work with an occupational therapist to introduce modified grips or utensils, allowing the patient to eat or write more independently. Additionally, I encourage patients to practice these skills regularly, reinforcing the importance of consistency and repetition in building their abilities. I also help patients build problem-solving skills to manage challenges they may encounter during recovery. Many stroke survivors face cognitive difficulties, such as memory issues, attention deficits, or problem-solving impairments. I incorporate cognitive rehabilitation techniques, working alongside neuropsychologists or speech therapists, to help patients improve these skills. This may involve memory exercises, strategies to improve attention, or training in decision-making. I encourage patients to practice these skills in their daily lives, starting with small, manageable tasks and gradually increasing the complexity as they progress. This approach not only helps with independence, but also boosts the patient's confidence in their ability to handle challenges that arise during recovery. Encouraging social interaction and community engagement is also a key part of promoting independence. Stroke survivors often experience social isolation due to physical or cognitive limitations. I work with patients to identify social activities or hobbies that they enjoy and that are achievable given their current abilities. This might include participating in community groups, attending support groups, or engaging in family activities. I also encourage stroke survivors to continue maintaining relationships with family and friends, as social support plays a vital role in recovery and maintaining emotional well-being. By fostering social interaction, I help patients reintegrate into their communities and reduce feelings of isolation or depression. Lastly, I emphasize the importance of self-advocacy in promoting independence. Stroke survivors often face various challenges in healthcare settings, such as navigating appointments, managing multiple healthcare providers, or understanding treatment options. I encourage patients to advocate for themselves by ensuring they understand their treatment plans, ask questions about their care, and seek support when needed. By empowering patients to be active participants in their healthcare decisions, I help them regain a sense of autonomy and control. In summary, promoting independence and self-management skills in stroke survivors requires a comprehensive, individualized approach that combines education, empowerment, adaptive techniques, and continuous support. By setting clear goals, providing education on self-care, teaching adaptive strategies, and fostering social connections, I help stroke survivors regain as much independence as possible and lead fulfilling lives post-stroke. My role as a nurse is not only to provide care, but to empower patients to take charge of their recovery and navigate the challenges of stroke rehabilitation with confidence and resilience.
Describe your understanding of goal setting in rehabilitation, e.g., SMART goals.
Goal setting in rehabilitation is a critical aspect of stroke recovery, as it provides direction, structure, and motivation for both patients and the healthcare team. The process involves identifying specific, measurable, achievable, relevant, and time-bound goals, often referred to as SMART goals, to ensure that the rehabilitation efforts are focused, effective, and meaningful to the patient's recovery journey. Understanding how to set these goals and tailor them to the individual patient is fundamental to promoting progress and fostering a sense of accomplishment during rehabilitation. The S in SMART stands for specific. Goals need to be clear and precise, avoiding any ambiguity about what the patient is working towards. For instance, rather than setting a vague goal like improve mobility, a more specific goal would be ambulate 50 feet with minimal assistance. This provides a clear target and gives both the patient and the rehabilitation team a concrete objective to work towards. Specific goals help to guide the patient's rehabilitation program, ensuring that interventions are purposeful and focused on addressing the most relevant aspects of the patient's recovery. The M stands for measurable. It is important to quantify progress so that both the patient and the team can track improvement over time. For example, a measurable goal might be increase grip strength by 10% within the next month, or perform upper body exercises for 20 minutes each day. By having a clear metric of success, the team can objectively assess whether the goal has been met and adjust the care plan if necessary. This also helps keep patients motivated, as they can visually see and experience their progress, which boosts their confidence and commitment to their rehabilitation. The A represents achievable. Goals should be realistic and attainable given the patient's current condition, abilities, and limitations. Setting goals that are too ambitious can lead to frustration and demotivation, while goals that are too easy may not stimulate enough progress. For instance, after a stroke, a goal such as walk independently without a cane within 1 month might be too ambitious for a patient with severe weakness, while a goal like increase walking distance by 10 feet each week could be more achievable. It is important to consider the patient's unique circumstances, including the severity of the stroke, comorbidities, and the resources available when setting achievable goals. The R in SMART stands for relevant. Goals should be meaningful and aligned with the patient's personal values, priorities, and long-term aspirations. A goal that is personally relevant to the patient, such as being able to feed myself without assistance, will encourage the patient to stay engaged in their rehabilitation program. Understanding what is most important to the patient and aligning rehabilitation goals with their values helps create a more motivating and individualized care plan. For example, if a patient's primary goal is to return to work, the rehabilitation team might focus on improving cognitive function, communication skills, and the ability to perform job-specific tasks, making the rehabilitation experience more relevant and purpose-driven. Finally, the T in SMART stands for time-bound. Each goal should have a defined timeline for completion. A time frame provides urgency and structure, helping both the patient and the team stay focused and motivated. For example, a time-bound goal could be perform 10 minutes of speech exercises daily for the next 2 weeks, or regain the ability to dress independently within 3 months. Having a specific time frame also allows for regular reassessment of the patient's progress, ensuring that the rehabilitation plan is dynamic and responsive to the patient's evolving needs. In practice, goal setting with stroke survivors involves collaboration with the patient, their family, and the interdisciplinary rehabilitation team. This process begins early in the rehabilitation journey, with an initial assessment of the patient's needs, abilities, and desires. Together, we set short-term and long-term goals, often breaking them down into smaller, more manageable steps to avoid overwhelming the patient and to build momentum. As the patient progresses, goals are regularly reviewed and updated to reflect their improving abilities, challenges, and changing priorities. The use of SMART goals is particularly important in stroke rehabilitation because it helps bridge the gap between clinical interventions and the patient's real-world function. By setting specific, measurable, achievable, relevant, and time-bound goals, we create a roadmap that not only addresses the physical, cognitive, and emotional aspects of recovery, but also ensures that the patient feels motivated, supported, and empowered in their rehabilitation process. Ultimately, goal setting helps the patient regain independence, improve their quality of life, and navigate the complexities of stroke recovery with confidence and purpose.
How do you assess a patient's progress and adjust the care plan accordingly?
Assessing a patient's progress and adjusting the care plan accordingly is a dynamic and ongoing process that requires a holistic approach, consistent monitoring, and effective collaboration with the interdisciplinary team. In stroke rehabilitation, where recovery can vary significantly between patients, it is essential to continuously evaluate both the patient's physical and emotional well-being, as well as their response to interventions. This process ensures that the rehabilitation plan remains relevant, responsive, and individualized, optimizing recovery outcomes. The first step in assessing a patient's progress involves regular and systematic evaluations. During each nursing shift, I conduct thorough assessments of the patient's physical status, neurological function, and psychosocial well-being. This includes monitoring vital signs, mobility, muscle strength, cognitive function, and any other stroke-related impairments. For example, if a patient is working on improving their walking ability, I might assess their gait, balance, and endurance by timing the distance they can walk independently. Similarly, if a patient is receiving speech therapy, I'll observe and document improvements or challenges in their ability to articulate, follow directions, or engage in conversation. These assessments are often supplemented by standardized tools, such as the Barthel Index for measuring functional independence or the Fuglemeyer Assessment for motor recovery, which provide objective data to track progress over time. Regular goal reviews are another crucial aspect of progress assessment. In line with the SMART goal framework, I routinely revisit the goals that were set at the beginning of rehabilitation and evaluate whether they remain realistic and achievable. During multidisciplinary team meetings or individual consultations with the patient, I assess whether the goals are being met, whether the patient is encountering barriers, and whether the timeline for completion is still appropriate. For example, if a patient's goal was to improve their fine motor skills to regain the ability to dress independently within 2 months, I assess whether they have reached that level of functioning or if they are facing unforeseen challenges such as spasticity or cognitive deficits. If a goal is not being met as anticipated, I work with the team to make adjustments, ensuring that we either modify the goal, extend the time frame, or introduce new interventions to address the barriers. Patient and family feedback plays an integral role in assessing progress. During regular interactions with the patient and their family, I ask open-ended questions about how they feel about the recovery process, any difficulties they are experiencing, and their level of satisfaction with the care they are receiving. For instance, a patient may report feeling increasingly fatigued or frustrated with their progress, even if objective measures show improvement. This feedback helps me gain insight into the psychological and emotional aspects of recovery, which are just as important as physical improvements. Emotional factors, such as depression or anxiety, can impede progress and should be addressed by adjusting the care plan accordingly. For example, if a patient is feeling emotionally overwhelmed, I might increase support from the social worker, refer them to counseling, or adjust rehabilitation sessions to ensure they don't feel overburdened. Another key part of assessing progress is identifying and addressing complications or setbacks that may arise. Stroke survivors are at risk of developing secondary complications such as muscle spasticity, contractures, dysphagia, or pressure ulcers, all of which can affect their recovery and require prompt attention. If I notice signs of complications during my assessments, I immediately communicate with the relevant specialists, such as physical therapists, speech therapists, or dietitians, to implement targeted interventions. For example, if a patient begins showing signs of aspiration or difficulty swallowing during meals, I may collaborate with a speech therapist to conduct a swallowing assessment and recommend adjustments to the patient's diet or positioning. This proactive approach ensures that complications are identified and addressed in a timely manner, preventing them from hindering the patient's recovery. Once progress is evaluated and any challenges are identified, I work with the multidisciplinary team to adjust the care plan. This collaboration involves physical therapists, occupational therapists, speech therapists, neuropsychologists, dietitians, and social workers. Together, we discuss the patient's progress, reassess their goals, and decide on any changes needed in their rehabilitation plan. For instance, if a patient has made significant progress in regaining mobility but is still struggling with cognitive deficits, the team may decide to focus more on cognitive rehabilitation techniques, while maintaining a reduced but still effective intensity of physical therapy. I also take into account the patient's preferences and personal circumstances when adjusting the care plan. For example, a patient who values being able to return to work might have goals adjusted to prioritize skills like concentration, problem-solving, or social interactions, in addition to physical mobility. Conversely, a patient who expresses a desire for greater independence at home might focus on ADLs such as dressing, cooking, or bathing. By integrating the patient's preferences into the care plan, I ensure that their rehabilitation journey remains relevant to their long-term goals and aspirations. Lastly, technology and assistive devices can play a role in adjusting the care plan. For patients who have plateaued in their recovery or who are struggling with certain tasks, introducing new technologies, such as robotic exoskeletons, virtual reality therapies, or assistive communication devices, can enhance progress. If a patient is struggling with motor coordination, I might introduce assistive devices like adaptive utensils or smart home technology to support their functional independence. In conclusion, assessing a patient's progress and adjusting the care plan is an ongoing and collaborative process. By conducting regular evaluations, reviewing goals, gathering patient and family feedback, addressing complications, and working with the multidisciplinary team, I ensure that the care plan remains aligned with the patient's needs, maximizes their recovery potential, and fosters their independence. This dynamic and patient-centered approach is key to ensuring the best possible outcomes in stroke rehabilitation.
What role does patient education play in long-term recovery and preventing secondary stroke?
Patient education plays a crucial role in long-term recovery and the prevention of secondary stroke. It is essential not only for helping patients understand the immediate aspects of their rehabilitation, but also for equipping them with the knowledge and skills they need to manage their health independently and reduce the risk of future strokes. Effective education empowers patients to make informed decisions, adopt healthier lifestyle habits, and recognize the signs of potential complications, all of which contribute to improved outcomes and long-term well-being. One of the primary goals of patient education in stroke recovery is to help patients understand the nature of their condition and the factors that contribute to their stroke. This includes explaining the different types of strokes, ischemic, hemorrhagic, and transient ischemic attacks, TIAs, as well as their symptoms, causes, and risk factors. By providing this foundational knowledge, patients can better understand the importance of managing their risk factors and adhering to a comprehensive care plan to reduce the likelihood of future strokes. For example, if a patient had a stroke related to high blood pressure or diabetes, educating them about the importance of controlling these conditions becomes a pivotal part of preventing another stroke. Patient education also plays a critical role in promoting medication adherence. Stroke survivors are often prescribed a range of medications, such as antiplatelets, anticoagulants, blood pressure medications, and statins, to manage their risk factors and prevent secondary strokes. I spend considerable time explaining the purpose, dosage, side effects, and potential interactions of these medications to ensure that patients fully understand their treatment regimen. I emphasize the importance of taking medications consistently and as prescribed, even if the patient is feeling better or is no longer experiencing symptoms. Failure to adhere to the prescribed medication regimen can increase the risk of another stroke. So ensuring that patients and their families understand how to properly manage these medications is key. Another important aspect of education is addressing lifestyle changes that can significantly reduce the risk of stroke recurrence. For instance, I provide detailed guidance on the importance of healthy eating, regular physical activity, smoking cessation, and weight management. I educate patients about the specific dietary recommendations that can help manage blood pressure and cholesterol, such as reducing sodium intake, increasing fruits and vegetables, and avoiding excessive alcohol consumption. For patients with diabetes, I also provide education on how to manage blood sugar levels through diet, exercise, and medication. Promoting physical activity is equally important, as regular exercise helps to improve cardiovascular health, reduce weight, and maintain blood pressure within healthy ranges. I often collaborate with physical therapists and dietitians to offer individualized plans that are both achievable and tailored to the patient's abilities. Furthermore, I stress the importance of monitoring blood pressure, blood sugar, and cholesterol levels regularly. I educate patients about how to track these parameters at home and when to seek medical attention if their levels fall outside of the desired range. Patients who understand the significance of early intervention and prevention are more likely to take proactive steps to protect their health and avoid complications that could lead to another stroke. Recognizing warning signs of a stroke or TIA is another critical element of patient education. I ensure that patients and their families are well versed in the signs and symptoms of a stroke, such as sudden weakness or numbness in the face, arms, or legs, difficulty speaking or understanding speech, and severe headache. I also educate them about the FAST acronym, face, arms, speech, time, as a simple way to remember the key symptoms and the importance of seeking immediate medical attention if any of these signs occur. This education can significantly reduce the time to treatment and improve the likelihood of better outcomes in the event of a subsequent stroke. Additionally, I provide education on managing psychosocial aspects of stroke recovery. Stroke survivors often experience emotional challenges, including depression, anxiety, and frustration, which can affect their ability to engage in rehabilitation and follow through with lifestyle changes. I work with the patient and their family to provide emotional support and encourage participation in support groups or counseling. Educating patients about the psychological impact of stroke, normalizing these feelings, and offering resources to manage mental health can help patients stay motivated and improve their long-term recovery prospects. Equally important is educating family members and caregivers. Stroke recovery often involves the support of family and friends, so ensuring that caregivers are knowledgeable about the patient's condition, rehabilitation needs, and the importance of providing emotional and physical support is crucial. I provide caregivers with information on assisting with activities of daily living, ADLs, managing medications, and understanding the potential complications of stroke, such as dysphagia or spasticity. Educating caregivers can help reduce the stress of caregiving, prevent burnout, and ensure that patients receive the optimal support they need to thrive. In addition to face-to-face education, I also use written materials, visual aids, and online resources to reinforce key information. Many stroke survivors benefit from having educational resources that they can revisit at home, which helps them remember important instructions, recommendations, and lifestyle changes. I also ensure that any materials provided are culturally appropriate and accessible to the patient, considering language barriers, literacy levels, and any disabilities. In summary, patient education is a cornerstone of long-term recovery and stroke prevention. By ensuring that patients and their families are well informed about stroke risk factors, treatment options, medication adherence, lifestyle changes, warning signs of a stroke, and the emotional challenges associated with recovery, I help them take an active role in their health and recovery process. This not only empowers patients to make better decisions, but also fosters a sense of control and optimism, which are essential for achieving long-term success and preventing future strokes.
Describe a challenging situation you encountered while caring for a stroke patient and how you resolved it.
One particularly challenging situation I encountered while caring for a stroke patient involved a patient named Mr. K, a 68-year-old male who had suffered a moderate ischemic stroke affecting the right hemisphere of his brain. He was experiencing severe hemiparesis on his left side, dysphagia, and expressive aphasia, which made communication extremely difficult. Mr. K was also struggling with significant emotional lability, a common issue after a stroke, often causing him to become frustrated or tearful without warning. The challenge arose when Mr. K became increasingly agitated and refused to participate in physical therapy sessions. Despite my team's best efforts, he would push away the therapists and verbally express his frustration, often becoming angry when asked to perform even simple movements. His frustration was exacerbated by his communication deficits. He couldn't find the words to express his needs, and this left him feeling helpless and isolated. As a result, his mobility started to decline, and we were worried that his emotional state would further hinder his recovery. I realized that the core of his resistance was not a lack of willingness, but a combination of emotional distress, communication barriers, and fear. Fear that his efforts might not lead to success or improvement. It became clear that I needed to approach this situation with patience, compassion, and a different communication strategy to build trust and help him overcome his frustration. The first step I took was to address his emotional needs. I spent time sitting with him each day, establishing a rapport, and allowing him to express his feelings in a safe and non-judgmental environment. During these interactions, I used simple nonverbal cues to encourage communication, such as pointing to objects or using a communication board to help him convey basic needs. I acknowledged his frustration and reassured him that it was normal to feel upset after a stroke, and that we were there to support him through the process. This gave him a sense of validation and control over his situation. Next, I collaborated with the speech therapist to work on alternative communication methods that would help reduce his frustration and make him feel more empowered in expressing himself. We introduced basic gestures and picture cards for him to use to indicate things like yes, no, or help. Over time, this helped him feel less isolated and enabled him to communicate more effectively with the care team. I also encouraged his family to participate in this communication process during their visits, reinforcing the idea that they were an active part of his recovery. Simultaneously, I worked with the physical therapy team to modify Mr. K's rehabilitation goals. We adjusted the intensity of the sessions to ensure that they felt achievable, setting small, incremental goals that would allow him to experience success and build confidence. For example, instead of focusing on walking long distances right away, we focused on improving his ability to sit up independently or move his arm with less effort. These small wins helped reduce his feelings of failure and kept him engaged in the process. One of the pivotal turning points came when we introduced short, positive reinforcement strategies during therapy sessions. When Mr. K successfully completed a small task, even something as simple as moving his arm or shifting his weight from side to side, I immediately praised his effort. We also encouraged his family to celebrate these moments of success, which helped him realize that progress was being made, even if it was slow. As he became more comfortable with the process and gained small victories, Mr. K began to gradually engage more in his rehabilitation. His emotional lability decreased as he felt more in control of his environment, and his frustration was significantly reduced. We were able to integrate relaxation techniques such as deep breathing and guided imagery to help him manage moments of anxiety or anger during physical therapy sessions. Over the course of a few weeks, his participation in therapy increased, and he began to show improvements in his strength and mobility. This experience reinforced the importance of addressing the holistic needs of stroke patients: physical, emotional, and psychological. By taking the time to truly listen to Mr. K, adjusting our approach to meet his specific needs, and focusing on building his confidence through small successes, we were able to break through his resistance and help him make significant strides in his recovery. It was a challenging situation, but it also underscored how important it is to work closely with the interdisciplinary team, involve family support, and always approach care with empathy and patience. The experience not only helped Mr. K regain his mobility and emotional stability, but also deepened my understanding of the complex nature of stroke recovery and the need for individualized care plans.
How do you prioritize nursing care for a stroke patient with multiple needs and potential complications?
Prioritizing nursing care for a stroke patient with multiple needs and potential complications requires a careful, systematic approach that ensures both immediate safety and long-term recovery. The complexity of stroke recovery, where patients may have a combination of neurological impairments, physical disabilities, emotional challenges, and potential complications, requires the ability to assess and respond dynamically to their evolving needs. I follow a structured, patient-centered approach to prioritize care that ensures the most critical aspects are addressed first, while still considering the holistic needs of the patient. The first step in prioritizing care is conducting a comprehensive assessment. Upon admission, I perform a detailed neurological and physical assessment to identify the immediate life-threatening issues. This includes evaluating airway patency, breathing, circulation, and neurological status using standard tools like the Glasgow Coma Scale, GCS. For example, if the patient has impaired airway protection due to dysphagia or decreased consciousness, addressing this issue becomes the immediate priority, as aspiration or airway obstruction could lead to severe complications, such as pneumonia. After stabilizing any life-threatening issues, the next priority is to manage the patient's mobility and physical safety. Many stroke patients have impaired motor skills, and this can increase their risk of falls, pressure injuries, and further functional decline. For a patient with hemiparesis or paralysis, I ensure that a fall risk assessment is completed, and I collaborate with the physical therapist to develop a plan for safe mobility. This includes making sure the patient is positioned properly in bed or in a chair, using assistive devices like a bedside table or mobility aids, and ensuring that proper techniques for transferring the patient are in place to prevent injury. I also conduct a skin assessment to monitor for pressure ulcers, especially if the patient is immobile, and adjust their position regularly to prevent breakdown. Managing complications is another crucial aspect of prioritizing care. Stroke patients are at high risk for a variety of complications, such as dysphagia, aspiration pneumonia, deep vein thrombosis, DVT, and spasticity. If the patient has dysphagia, I collaborate closely with the speech therapist to ensure that the patient is evaluated for safe swallowing techniques. In cases of impaired swallowing, I adjust the diet to a safer consistency, and if necessary, I implement measures such as feeding assistance or nasogastric tube placement. Additionally, aspiration precautions, such as upright positioning during meals and thickened liquids, are put into place to minimize the risk of pneumonia. For stroke patients who are at high risk of DVT, I prioritize mobility, leg exercises, and the use of compression stockings or anticoagulant therapy to prevent clot formation. If a patient has severe spasticity, I work with the team to develop a plan for managing it, which may include medications such as muscle relaxants or botulinum toxin injections and physical therapy to improve range of motion. Once life-threatening conditions and immediate risks are addressed, I focus on the patient's neurological and cognitive rehabilitation. For patients with cognitive deficits, such as memory loss or confusion, I engage them in activities to promote cognitive function, such as using memory aids, simple cognitive exercises, or orienting questions during interactions. I also work closely with the neuropsychologist to assess for depression or anxiety, which are common after strokes. If emotional lability or depression is noted, I ensure the patient is supported through psychosocial interventions, such as counseling or support groups. Educating the patient and family about these potential emotional challenges is essential for their understanding and long-term adjustment. I also prioritize patient education and family involvement. This is particularly important in stroke care, as the rehabilitation process can be lengthy, and there are often many lifestyle changes to be made, including dietary modifications, medication adherence, and increased physical activity. I provide the patient and their family with education on stroke prevention, such as managing hypertension, diabetes, and cholesterol, and I emphasize the importance of taking prescribed medications to prevent secondary strokes. For families, I offer guidance on caregiver support, managing emotional responses, and the physical demands of caregiving. The care plan is regularly reevaluated and adjusted based on the patient's changing needs. As the patient progresses in recovery, goals are modified, and new interventions are introduced as necessary. For example, once a patient stabilizes physically, we shift the focus toward maximizing independence and improving quality of life, including mobility training, communication skills, and social integration. Throughout the rehabilitation process, I remain in close communication with the multidisciplinary team, including physical therapists, speech therapists, occupational therapists, and social workers, to ensure that the patient's evolving needs are met. In cases where the patient has multiple and complex needs, I prioritize the patient's immediate physical safety and functional recovery, while ensuring that psychosocial and emotional support is integrated into the care plan. Balancing these priorities requires constant communication, flexibility, and a thorough understanding of the patient's goals and expectations. In conclusion, prioritizing care for a stroke patient with multiple needs and potential complications is about addressing life-threatening conditions first, while simultaneously ensuring that the patient's rehabilitation goals are met. A patient-centered approach, involving clear communication and collaboration with the interdisciplinary team, is essential to providing comprehensive care that maximizes recovery and minimizes the risk of complications.
What steps do you take when you notice a change in a stroke patient's neurological status?
When I notice a change in a stroke patient's neurological status, I follow a clear, systematic approach to quickly assess the situation and take appropriate action. Changes in neurological status can be indicative of serious complications, such as a secondary stroke, increased intracranial pressure, or other acute issues, and addressing them promptly is crucial for patient safety and optimal outcomes. The first step I take is to perform a thorough neurological assessment. I begin by evaluating the patient's level of consciousness, using tools such as the Glasgow Coma Scale, GCS, to assess responsiveness and alertness. This provides a baseline and allows me to identify any significant changes. I also assess pupil size and reaction, speech, motor function, and sensation to check for signs of worsening neurological impairment. Any focal deficits, such as weakness, numbness, or speech difficulties, are noted and compared to previous assessments. After gathering this information, I immediately notify the physician or neurologist if the changes are significant or if there is any concern about a secondary stroke or other neurological event. Timely communication with the medical team is essential for further diagnostic evaluation and management. Depending on the patient's condition, the physician may order additional tests, such as a CT scan or MRI to assess for acute changes in the brain, such as ischemia, hemorrhage, or edema. If the patient's neurological changes are associated with increased intracranial pressure, ICP, I take immediate steps to manage the patient's airway, breathing, and circulation. For instance, I position the patient with their head elevated to 30 degrees to help reduce ICP, and I ensure that the environment is quiet and free from excessive stimulation to prevent further increases in pressure. If necessary, I prepare for the administration of medications, such as mannitol or hypertonic saline, as ordered by the physician, to reduce swelling. In cases where I notice sudden deterioration in motor function or language deficits, I ensure that a stroke protocol is initiated without delay, including a reassessment of vital signs and potentially the reevaluation of the patient's risk for another stroke. I work closely with the interdisciplinary team, including physical therapists and speech therapists, to reassess any changes in mobility, swallowing, and communication abilities. If dysphagia is suspected, I immediately implement aspiration precautions to prevent choking or pneumonia and notify the speech therapist for a bedside swallow assessment. While waiting for further instructions from the physician or neurologist, I also monitor the patient's vital signs closely. Changes such as elevated blood pressure, tachycardia, or changes in oxygen saturation could indicate potential complications like hypertension or respiratory distress, which may require urgent intervention. I ensure that the patient remains in a safe environment, free from unnecessary stimulation, and closely monitor for any signs of seizures or cardiac arrhythmias, both of which could be precipitated by neurological changes. Alongside these immediate actions, I continue to document all observations in the patient's chart, noting the time of onset, any related symptoms, and interventions taken. This documentation is essential for tracking the progression of the patient's condition and providing a clear record for the medical team to make informed decisions. Once the physician has been informed and diagnostic tests are underway, I update the patient's family on the situation in a clear and compassionate manner, explaining the steps we are taking to ensure the patient's safety and recovery. In my communication with the family, I provide them with supportive information about what the changes in neurological status might indicate and how we are addressing the situation. As the situation evolves, I reassess the patient regularly, keeping a close watch on neurological changes, vital signs, and overall clinical status. If necessary, I adjust the care plan to address any new or emergent needs, such as additional neuroprotective measures, enhanced pain management, or further rehabilitative interventions. In summary, when I notice a change in a stroke patient's neurological status, my approach is to first assess the situation thoroughly, communicate immediately with the physician or medical team, implement appropriate interventions, and monitor closely for further deterioration. Rapid response and a coordinated effort with the interdisciplinary team are crucial in ensuring that the patient receives timely and effective care.
How do you handle disagreements or conflicting opinions within the interdisciplinary team?
Handling disagreements or conflicting opinions within the interdisciplinary team requires a balanced approach that emphasizes respectful communication, collaboration, and a shared focus on the patient's best interests. In my experience, conflicts can arise when different team members have different perspectives based on their areas of expertise or clinical priorities. However, addressing these differences constructively is vital to providing optimal care for the patient. The first step I take is to actively listen to all perspectives involved. I ensure that each team member has the opportunity to express their concerns or recommendations without interruption. By creating a space where everyone feels heard, we can often identify the root cause of the disagreement, whether it's a difference in interpretation of clinical data, treatment philosophies, or even a miscommunication. In my role as a nurse, I make sure to respect each discipline's knowledge and expertise, whether it's from physical therapy, speech therapy, or neurology, recognizing that each team member brings valuable insights to the table. Once all perspectives are clearly understood, I focus on finding common ground. I often initiate discussions where we can all align on the primary goal, the patient's recovery and well-being. For example, if there's a disagreement on the approach to pain management or the level of intensity in rehabilitation therapy, I help the team refocus on the patient's long-term rehabilitation goals and their functional needs. From there, we can explore potential compromises or alternative approaches that still support the patient's overall care plan. In cases where a compromise cannot be reached, I encourage a structured decision-making process. This may involve gathering more evidence, such as recent clinical studies, patient history, or consultations with specialists, to guide the decision. I always ensure that the final decision is patient-centered, meaning that any choice made should be in the best interest of the patient's safety, comfort, and recovery. If the disagreement persists and a resolution seems difficult to achieve, I believe in escalating the issue appropriately. In situations where the conflict involves significant clinical concerns or poses a risk to patient care, I might involve a supervisor, medical director, or clinical coordinator to mediate the discussion and help the team reach a consensus. Having a neutral third party can sometimes facilitate a more productive conversation, ensuring that all concerns are addressed in a professional and timely manner. Throughout the process, I always strive to maintain professionalism and focus on the shared goal of providing high-quality patient care. I also try to foster an atmosphere of mutual respect within the team, emphasizing that disagreements are a natural part of collaboration in healthcare, but they should always be handled with courtesy and open-mindedness. Encouraging ongoing, transparent communication is essential for preventing future conflicts and ensuring that the team functions effectively as a whole. Ultimately, I believe that the interdisciplinary team's success is built on strong communication, a commitment to the patient, and a shared willingness to compromise when necessary. This collaborative approach leads to better decision-making and ensures that the patient's care is comprehensive, well-coordinated, and ultimately aligned with their needs and goals.
What is your understanding of professional boundaries in the nurse-patient relationship in stroke rehabilitation?
Professional boundaries in the nurse-patient relationship are crucial for ensuring that the care provided is both effective and ethical, while also protecting the well-being of both the patient and the nurse. In stroke rehabilitation, where patients may experience physical, emotional, and cognitive challenges, maintaining these boundaries becomes even more important due to the vulnerability and dependency that often accompany recovery. I understand professional boundaries to be the framework that defines the appropriate limits of the relationship between the nurse and the patient, ensuring that care is provided in a respectful, compassionate, and therapeutic manner without overstepping personal or professional lines. First and foremost, I recognize that my role as a nurse is to provide clinical care that is focused on the patient's health and rehabilitation goals. While I strive to build rapport and trust with my patients, particularly in stroke rehabilitation where emotional support is critical, I always ensure that this relationship remains centered on patient care and not personal involvement. This means maintaining professionalism in all interactions, setting clear boundaries between the professional and personal aspects of the relationship. For instance, in stroke rehabilitation, patients may develop a deep sense of vulnerability, especially if they have communication difficulties or physical impairments that impact their independence. This can sometimes lead to patients developing a dependence on the nurse, seeking emotional reassurance or closeness. While it's important to be empathetic and offer support, I recognize that crossing into a personal or emotional role beyond that of a healthcare provider can lead to potential issues, such as inappropriate reliance or emotional attachment. Therefore, I ensure that my approach is always professional, offering support without becoming overly involved in personal matters or developing a relationship that could interfere with my clinical objectivity. Another important aspect of professional boundaries involves respecting patient autonomy. In stroke rehabilitation, patients may experience significant cognitive or emotional challenges, which could impair their ability to make decisions. While I always advocate for their needs, it is essential to support shared decision-making rather than making decisions for the patient without their input. I provide clear, concise information about treatment options, involve the patient in goal setting, and respect their wishes when appropriate, even if they are unable to communicate clearly. However, if a patient is unable to make informed decisions due to cognitive impairment, I collaborate with the interdisciplinary team, including the family or legal guardian, to ensure that decisions are made in the patient's best interest while still upholding their dignity. Additionally, maintaining physical boundaries is an essential component of the nurse-patient relationship. In stroke rehabilitation, many patients experience physical limitations and may require assistance with personal care tasks, such as bathing, dressing, or transferring. It's important to ensure that any physical touch is therapeutic, respectful, and necessary for the patient's care. I always explain each step of the process and seek the patient's consent, even if they have cognitive impairments. For patients with communication difficulties, I use nonverbal cues or gestures to help ensure their comfort and willingness to engage in the required care activities. Professional boundaries also extend to maintaining confidentiality and respecting the patient's privacy. In stroke rehabilitation, especially when patients are often undergoing intensive therapy and sharing personal health information, confidentiality is critical. I adhere to established legal and ethical standards regarding the handling of sensitive health information, ensuring that any communication with colleagues or family members is done within the scope of patient consent and privacy laws. In addition to these boundaries, I maintain an awareness of the emotional needs of patients in rehabilitation. Stroke patients often experience grief, depression, and anxiety related to the changes in their physical and cognitive abilities. I approach these emotional challenges with compassionate care, providing a supportive environment that encourages expression but without becoming overly involved in personal emotional matters. For example, if a patient expresses sadness or frustration, I acknowledge their feelings and provide emotional support, but I do not cross into the role of therapist or counselor. Instead, I refer them to qualified mental health professionals, such as a neuropsychologist or social worker, who can provide the appropriate emotional and psychological care. Lastly, I always strive to maintain clear professional communication with the patient's family and caregivers. In stroke rehabilitation, families often play a crucial role in the patient's recovery, but it's important to respect the patient's wishes when communicating with them. I ensure that I have the patient's consent before sharing any medical information with family members, and I make sure that the patient is part of the discussion when possible, empowering them to be involved in their own care and rehabilitation process. In summary, my understanding of professional boundaries in the nurse-patient relationship in stroke rehabilitation is rooted in respect, clear communication, and maintaining a therapeutic rather than personal relationship. These boundaries help ensure that the care provided is focused on the patient's well-being, recovery, and autonomy, while also safeguarding the integrity of the nurse-patient dynamic. By maintaining these boundaries, I can provide the highest quality of care and support to stroke patients while also fostering a respectful and professional environment for everyone involved.
How do you stay up to date with the latest research and best practices in stroke rehabilitation nursing?
Staying up to date with the latest research and best practices in stroke rehabilitation nursing is essential to ensuring that the care I provide is evidence-based, effective, and aligned with the most current advancements in the field. As the field of stroke rehabilitation evolves rapidly, it's crucial to be proactive in seeking out opportunities for learning and professional development. First, I regularly engage with professional journals and publications focused on stroke care and rehabilitation, such as those published by the American Stroke Association or the Journal of Stroke and Cerebrovascular Diseases. These journals provide valuable insights into new research findings, innovative rehabilitation techniques, and clinical guidelines. I make it a habit to review these publications either monthly or quarterly to stay informed on emerging trends and evidence-based practices in stroke care. In addition to reading journals, I also participate in professional conferences and workshops dedicated to stroke rehabilitation. These events are excellent opportunities for networking with experts in the field and attending specialized sessions on topics such as neuroplasticity, rehabilitation technologies, and patient-centered care strategies. They provide a platform to learn from renowned researchers and clinicians about the latest interventions, rehabilitation tools, and approaches that improve patient outcomes. I also rely on online courses and webinars that focus on stroke rehabilitation and nursing practices. Many reputable organizations, such as the World Stroke Organization, WSO, and National Stroke Association, offer online training modules and seminars. These courses help me keep my skills current in areas such as neurological assessments, spasticity management, and patient education techniques. Additionally, some institutions provide continuing education credits that ensure I maintain and expand my knowledge base while meeting professional licensure requirements. Staying informed about clinical guidelines is another essential part of my approach. For example, I regularly review and incorporate the latest clinical practice guidelines for stroke rehabilitation provided by bodies like the American Heart Association/American Stroke Association, AHA/ASA, or National Institute for Health and Care Excellence, NICE. These guidelines offer detailed recommendations on aspects such as acute care management, rehabilitation protocols, and long-term stroke prevention. By staying current with these, I ensure that the care I provide is consistent with best practices and aligned with international standards. In addition to formal learning opportunities, I actively participate in peer discussions and case study reviews with my colleagues and interdisciplinary team members. This collaborative environment encourages knowledge exchange and enables me to stay informed about new developments, challenges, and successful strategies that others are implementing in their practice. I value the interdisciplinary perspective, as it provides insights from physical therapy, speech therapy, occupational therapy, and psychology, all of which contribute to a more comprehensive understanding of stroke rehabilitation. To ensure that I'm incorporating the latest technologies and rehabilitation tools in my practice, I also engage with medical device manufacturers and attend product demonstrations or workshops on new assistive technologies. As stroke rehabilitation often involves the use of mobility aids, virtual reality therapy, or robot-assisted therapy, staying informed about the latest innovations ensures that I can offer patients cutting-edge tools that enhance their rehabilitation process. Lastly, I believe in self-reflection and continuously assessing my own practice. After learning about new research or guidelines, I evaluate how they can be integrated into my own clinical settings. If I notice areas in which I could improve, such as incorporating a new therapy modality or modifying my patient education techniques, I take steps to adjust my approach. This commitment to lifelong learning ensures that I continue providing the highest standard of care to my patients. In summary, staying up to date with the latest research and best practices in stroke rehabilitation nursing involves a combination of reading professional journals, attending conferences, participating in continuing education, engaging in peer discussions, and implementing new technologies and clinical guidelines. By remaining proactive in my learning, I can ensure that I am offering the most effective, evidence-based care to stroke patients, which ultimately contributes to their successful recovery and improved quality of life.
Are you familiar with any specific certifications or advanced training in stroke rehabilitation, e.g., CRRN?
Yes, I am familiar with several certifications and advanced training programs that are highly relevant to stroke rehabilitation nursing, and I recognize the value they bring to enhancing both my knowledge and clinical skills. One such certification that I find particularly valuable is the Certified Rehabilitation Registered Nurse, CRRN, which is widely recognized in the field of rehabilitation nursing. While I do not currently hold the CRRN certification, I have actively pursued advanced training in stroke rehabilitation and am committed to continuing my professional development in this area. I am planning to sit for the CRRN exam in the near future, as I believe it would further strengthen my expertise in rehabilitation nursing and deepen my understanding of evidence-based practices in stroke recovery. In addition to the CRRN, I have participated in stroke-specific continuing education courses, which have helped me stay up to date with the latest developments in stroke care. These courses have provided me with valuable insights into neuroplasticity, spasticity management, and advanced rehabilitation techniques that directly benefit my patients. I have also attended workshops and webinars hosted by reputable organizations such as the American Stroke Association and World Stroke Organization, which have helped me stay informed about emerging technologies and innovative rehabilitation interventions. Moreover, I am familiar with other certifications that may complement stroke rehabilitation, such as neurodevelopmental treatment, NDT, and lymphedema therapy, both of which can be useful in treating the multifaceted needs of stroke survivors. I also stay connected with professional networks and online platforms that offer peer-reviewed research and advanced clinical strategies, which continue to inform my daily practice. Overall, I believe that investing in certifications and advanced training, particularly those related to stroke rehabilitation, is essential for providing the best possible care to patients. I am committed to furthering my education and clinical expertise in this field, and I see obtaining certifications like the CRRN as a natural next step in my career development.
How do you handle the emotional demands of working with individuals who have experienced a significant neurological event?
Working with individuals who have experienced a significant neurological event, such as a stroke, can undoubtedly be emotionally demanding. I believe that maintaining emotional resilience and a professional boundary while providing compassionate care is essential in managing the emotional challenges of this role. In my experience, I find that maintaining a balance between empathy for my patient's struggles and self-care is key to navigating the emotional demands. First, I focus on emotional support by acknowledging the patient's emotional state and providing reassurance. Stroke survivors often face profound changes in their lives, physically, cognitively, and emotionally, and this can create feelings of frustration, fear, or even grief. I take the time to listen to my patients, validate their experiences, and create a safe space for them to express their feelings. This kind of emotional support is crucial, especially when patients are coming to terms with significant limitations or a loss of independence. While doing so, I am careful to ensure that my interactions remain professional and focused on the patient's well-being, avoiding the development of personal emotional attachments that might blur professional boundaries. One of the most challenging aspects of this work is witnessing patients' emotional highs and lows, as they may have moments of hope and optimism in their recovery, followed by setbacks that lead to disappointment or anger. I approach this by remaining emotionally grounded and offering consistent encouragement, emphasizing the progress that has been made, even if it is small. In these moments, I also ensure that I am mindful of my own emotional reactions, knowing that taking on too much emotional stress can impact my ability to provide high-quality care. To cope with the emotional demands, I make sure to practice self-care regularly. This involves activities outside of work that help me maintain my mental and emotional health, such as exercise, spending time with loved ones, or engaging in hobbies that help me decompress. Additionally, I believe in the importance of debriefing with colleagues and the interdisciplinary team. Sharing challenging experiences with fellow professionals not only helps to process difficult emotions, but also fosters team solidarity and allows us to offer each other support. Whether it's discussing a particularly difficult case or sharing coping strategies, these conversations can help reduce emotional burnout and promote a healthier work environment. Furthermore, I seek guidance from mental health professionals or participate in workshops that provide training on managing emotional stress and compassion fatigue. As healthcare providers, we are often at risk of emotional exhaustion due to the intensity of our work. By continually learning techniques for emotional resilience, I can remain focused on delivering compassionate care while also protecting my own emotional well-being. Ultimately, I find that empathy combined with boundaries and self-care allows me to continue offering the best care possible to stroke survivors without compromising my own emotional health. I deeply value the relationships I build with patients and their families, but I recognize that maintaining emotional resilience and balance is key to sustaining a long-term, effective nursing career in this challenging and rewarding field.
A patient with left-sided weakness is refusing to participate in their physical therapy session. How would you approach this situation?
In a situation where a patient with left-sided weakness is refusing to participate in their physical therapy session, my approach would be centered around understanding the underlying reasons for their refusal and then using effective communication and motivational strategies to encourage their participation. I understand that refusal to engage in therapy can stem from a variety of emotional, psychological, or physical factors, and addressing these factors is essential in ensuring the patient's overall recovery. First, I would approach the patient with empathy and a calm, non-judgmental demeanor. I recognize that stroke recovery can be a frustrating and emotionally challenging process, and there may be fear, frustration, or even shame associated with participating in physical therapy, especially if the patient has experienced a loss of independence. I would give the patient space to express their feelings and allow them to share any concerns they might have. I would ask open-ended questions, such as, Can you tell me what's making it hard for you to want to participate in therapy today? Or are there specific parts of therapy that make you feel uncomfortable or frustrated? Once the patient has had the chance to express their concerns, I would validate their feelings while gently reinforcing the importance of therapy. For example, if the patient is feeling discouraged by their progress or fearful of pain, I would acknowledge these emotions and let them know that it's completely normal to feel that way. I would reassure them that therapy is tailored to their current abilities and that small steps are often the most effective in achieving long-term progress. I would also emphasize the role that therapy plays in regaining independence and improving quality of life, helping the patient to see the direct connection between their participation and their recovery goals. If there are concerns about pain or discomfort during the therapy session, I would work with the physical therapist to ensure that any exercises or movements are modified to accommodate the patient's current physical limitations. I would offer the patient reassurance that pain management strategies are in place and their comfort is a priority. Sometimes, simply acknowledging that they are in control of how much they push themselves during therapy can help reduce anxiety or fear about the process. If the patient's refusal stems from psychological barriers, such as depression or low motivation, I would gently explore these feelings and, if needed, refer the patient to a psychologist or social worker for further support. Depression is common among stroke patients, and it can significantly impact their willingness to engage in rehabilitation. I would also consider involving the patient's family or caregivers to offer encouragement and reinforce the importance of therapy, while ensuring that the patient feels empowered and respected in making decisions about their care. In addition, I would highlight the small successes the patient has achieved, even if they seem insignificant. For example, if the patient has made any improvements in strength, coordination, or range of motion, I would remind them of these achievements to foster a sense of progress and motivation. Celebrating even the smallest milestones can help shift their focus from what they cannot do to what they are capable of accomplishing. Lastly, I would make it clear that therapy is a collaborative process. I would encourage the patient to communicate their concerns with the physical therapist directly, and I would assure them that their input is valued in developing a plan that works best for them. By fostering a sense of teamwork, I hope to empower the patient and motivate them to become more involved in their rehabilitation journey. If the patient still refuses to participate after these discussions, I would ensure that their decision is respected while continuing to monitor their progress and emotional state. I would remain supportive and available for future conversations about the importance of therapy, reinforcing that rehabilitation is a gradual process and that they can always resume therapy when they feel ready. I would also collaborate with the interdisciplinary team to ensure that the patient's emotional well-being is addressed and any other barriers to participation, such as pain, anxiety, or depression, are properly managed. In summary, my approach to a patient refusing physical therapy would involve understanding the root cause of their reluctance, offering empathy and reassurance, modifying the therapy plan if needed, and encouraging collaboration and patient empowerment. By addressing the emotional and psychological factors at play, I aim to help the patient feel supported and motivated to engage in their rehabilitation process.
A patient with expressive aphasia is trying to communicate their needs but is becoming increasingly frustrated. What strategies would you use?
When caring for a patient with expressive aphasia who is becoming increasingly frustrated while trying to communicate their needs, my primary goal would be to help them feel heard, understood, and empowered despite the barriers in communication. Expressive aphasia can be an incredibly challenging condition for both the patient and the caregiver, as it impacts the patient's ability to articulate their thoughts, which often leads to frustration and feelings of helplessness. My approach would focus on patience, adaptability, and nonverbal communication techniques to reduce frustration and foster a supportive environment. The first step I would take is to ensure that I approach the patient with calmness and empathy. I recognize that their frustration is a natural response to their inability to express themselves clearly, and it's important to validate their feelings. I would offer reassuring statements, such as, "I can see you're feeling frustrated, and I want to help you. Let's take our time and figure this out together." To facilitate communication, I would employ alternative methods that make it easier for the patient to express themselves. For example, I would use visual aids, such as picture boards or communication cards, that allow the patient to point to images or symbols representing their needs. If the patient is able to write, I would encourage them to write down their thoughts or needs, providing them with a pen and paper or a whiteboard. If the patient is not able to use writing or picture cards effectively, I would focus on using simplified questions and offering yes/no options. For example, I might say, "Are you feeling pain? Yes or no?" Or, "Would you like a drink of water? Yes or no?" This approach can reduce the cognitive load on the patient, as it offers a clear choice without overwhelming them with a need to form complex sentences. Additionally, I would pause frequently to give them time to process and attempt a response, understanding that their thought-to-speech process may take longer. Another technique I would use is nonverbal communication. I would pay close attention to the patient's body language, facial expressions, and gestures, as these can often convey important information about their needs or emotional state. I would remain attentive and make sure that the patient knows I am actively listening, even if their verbal communication is limited. For instance, if the patient is pointing toward a specific area of their body, I would gently explore whether they are indicating discomfort or needing help with something specific. If the patient's frustration seems to escalate, I would remain calm and patient, allowing them space to regain composure. I understand that pushing them too quickly to communicate can increase their frustration, so I would offer comfort by saying something like, "Take your time. We're in no rush. I'm here with you." If the frustration is tied to a specific need or symptom, such as pain, I would work to address it as quickly as possible to alleviate the source of distress. In cases where communication continues to be difficult, I would involve the speech-language therapist, SLT, in the care plan. Speech-language therapists are specialists in helping individuals with aphasia, and they can provide both therapeutic interventions and strategies tailored to the patient's specific level of aphasia. They may also help create a long-term communication plan that makes it easier for the patient to express their needs and feelings as they progress in their recovery. I would also ensure that the patient's family members are involved in the process, providing them with education on aphasia and communication strategies they can use at home. Family members can be vital in reducing frustration by offering consistent, patient support and reinforcing the patient's efforts to communicate. Throughout the interaction, I would aim to create a calm environment, minimizing distractions that could contribute to the patient's frustration. I would ensure that the atmosphere is one of support and encouragement, focusing on the patient's efforts rather than their difficulties. It's important to celebrate small successes in communication, reinforcing the patient's progress and boosting their confidence. In summary, my approach to caring for a patient with expressive aphasia who is becoming frustrated would include using simplified language, alternative communication methods like picture boards or yes/no questions, focusing on nonverbal cues, remaining patient and empathetic, and involving both the interdisciplinary team and family members for ongoing support. These strategies would aim to reduce frustration, improve communication, and foster a sense of empowerment in the patient during their recovery process.
A family member expresses unrealistic expectations about the patient's recovery timeline. How would you address their concerns?
When a family member expresses unrealistic expectations about a patient's recovery timeline, it's essential to approach the situation with empathy, clarity, and education. I understand that family members often have high hopes for their loved one's recovery, and they may not be fully aware of the complexities of stroke rehabilitation or the often gradual nature of recovery. My goal would be to help them understand the recovery process while maintaining their hope and involvement in a realistic and supportive way. First, I would listen carefully to the family members' concerns and allow them to express their expectations and fears. I would acknowledge their emotional investment and the fact that they are likely feeling both hopeful for their loved one's recovery and possibly worried about the future. For example, I might say, "I understand that you want the best possible recovery for your loved one, and it's natural to hope for a quick return to normal. The recovery process can be unpredictable, but I want to make sure we set realistic goals that will support the best possible outcome. Once I have a clear understanding of their concerns, I would gently explain the individual nature of stroke recovery. I would explain that recovery timelines can vary greatly depending on factors such as the severity of the stroke, the areas of the brain affected, the patient's overall health, and their commitment to rehabilitation. I would share that recovery is typically gradual, with progress often being more noticeable in the early stages but continuing to improve over time, even if it's at a slower pace. I would also make it clear that some aspects of recovery, such as neuroplasticity, can take months or even years to manifest fully. I would then work to set realistic, achievable goals for the patient and their family. I would collaborate with the interdisciplinary team to establish short-term goals that can be met during the current phase of rehabilitation, while also explaining that long-term recovery can be unpredictable and require ongoing support. For example, I might say, in the short term, we can focus on improving strength, coordination, and speech, but it's important to recognize that full recovery from a stroke can take time, and progress may be slow at times. To further support their understanding, I would provide information on the typical recovery stages for stroke survivors, explaining the acute, subacute, and chronic stages. I would also refer to the patient's individual progress, emphasizing the small successes and milestones that are already being achieved. Sharing objective measures of progress, such as improvements in mobility, speech, or independence, can help the family see that even if the recovery timeline isn't as fast as they hoped, significant strides are being made. Additionally, I would emphasize that recovery from a stroke is not just about physical improvement, but also about emotional and psychological adjustment. I would remind them that coping with the emotional and cognitive impacts of a stroke can take time, and it's just as important as the physical recovery. For example, I might say, the journey to recovery includes not only physical improvements, but also adapting emotionally and psychologically. We are here to support both the physical and mental well-being of your loved one. Finally, I would offer the family member resources for additional support, such as stroke support groups, counseling, or educational materials about stroke recovery. These resources can help them understand the process better, manage their expectations, and build a support system for themselves as they navigate this challenging time. In situations like this, it's crucial to remain patient and non-judgmental, offering clarity and understanding without diminishing the family's hopes. By fostering open communication and setting realistic expectations, I can help the family feel more empowered and involved in the recovery process, without setting them up for disappointment. In summary, addressing unrealistic expectations involves actively listening to the family's concerns, explaining the individual and gradual nature of stroke recovery, setting realistic goals, and offering educational resources and support. This approach helps to align the family's expectations with the reality of stroke recovery while maintaining their involvement in a positive, informed way.
A patient develops signs of a urinary tract infection during their rehabilitation. What are your nursing interventions?
When a patient develops signs of a urinary tract infection, UTI, during rehabilitation, prompt and effective nursing interventions are essential to prevent further complications, manage the infection, and ensure the patient's recovery remains on track. I would follow a comprehensive approach that includes assessment, collaboration with the healthcare team, and patient education, while prioritizing comfort and infection control. The first step would be to perform a thorough assessment of the patient's symptoms. Common signs of a UTI include increased frequency of urination, urgency, pain or burning during urination, cloudy or foul-smelling urine, fever, or change in mental status, particularly in stroke patients who may have cognitive impairments. I would carefully assess whether the patient is experiencing any of these symptoms or if they show any signs of discomfort that could be related to urinary issues. Once I have identified that the patient is showing symptoms of a UTI, I would notify the physician or healthcare provider immediately to get guidance on the appropriate diagnostic tests and treatment. This may include urine analysis and culture to confirm the diagnosis and determine the causative organism. It's important to gather a clean catch urine sample if possible, following proper sterile technique, to prevent contamination and ensure accurate results. While waiting for results, I would initiate empiric treatment based on the healthcare provider's orders, which may include antibiotics to treat the infection. I would also ensure that the patient is hydrated, as adequate fluid intake is crucial for flushing out bacteria from the urinary tract. If the patient has any difficulty with fluid intake, I would work with the interdisciplinary team to find strategies to encourage hydration, such as offering preferred beverages, using straws, or providing smaller, more frequent amounts of fluid. In addition, I would monitor the patient's vital signs, especially temperature, to track any signs of systemic infection such as fever or chills. If the patient shows signs of sepsis, such as confusion, a rapid heart rate, or low blood pressure, I would escalate care immediately and follow the institution's protocol for sepsis management. To support the patient's comfort, I would provide pain relief measures for symptoms such as burning during urination or discomfort in the lower abdomen. This might include non-pharmacological interventions like applying a warm compress to the lower abdomen or offering analgesics as prescribed. I would also ensure that the patient is comfortable and aware of any changes in their usual care routines related to their symptoms. Another key intervention would be to evaluate the patient's urinary habits and assist with timely toileting. Some patients, particularly those with mobility issues, may not void as frequently as necessary, leading to urinary retention, which can contribute to UTIs. I would work with the nursing team and the occupational therapist to ensure that the patient is being encouraged to void regularly to reduce the risk of infection. If the patient requires assistance with toileting, I would ensure that they are provided with a safe and timely way to access the restroom. I would also focus on maintaining proper perineal hygiene, particularly for patients who have difficulty cleaning themselves due to weakness or immobility. I would make sure that the patient is wiped from front to back to prevent bacteria from the rectum spreading to the urethra. If the patient has an indwelling catheter, if applicable, I would ensure it is maintained according to a septic technique to prevent catheter-associated urinary tract infections, CAUTIs. This includes regular cleaning of the catheter and monitoring for signs of infection at the insertion site. As part of the patient education process, I would educate the patient, if possible, and their family or caregivers about the importance of hydration and urinary hygiene to prevent future UTIs. For example, I would discuss the benefits of wiping techniques, wearing cotton underwear, and encouraging frequent urination. If appropriate, I would also discuss the possible role of cranberry products or other dietary changes as part of the patient's overall prevention strategy, while recognizing that these should not replace medical treatment or antibiotics. Finally, I would follow up on the patient's progress and response to treatment, ensuring that their symptoms are improving. If necessary, I would arrange for further diagnostic testing or follow-up appointments to ensure that the UTI has been fully treated and to monitor for any potential complications, such as antibiotic resistance or the development of chronic UTIs. In summary, my nursing interventions for a patient with signs of a urinary tract infection would include thorough assessment, timely communication with the healthcare provider, initiation of appropriate treatments, monitoring for complications, ensuring comfort, and providing education on prevention strategies. By implementing a comprehensive care plan, I can help manage the infection effectively while supporting the patient's overall rehabilitation process.